شايفين السكرين كلكم يا جماعة؟
أي واضح دكتور.
اوكي، رح بلش.
ستارت.
Okay. If you recall, 2 weeks ago, we were talking about the clavicle, and when we reached towards the end, we had passed through 3 hours already, and we decided to carry on next week, the week after. Now, I will like to mention that I would like to finish the previous lecture and then go on to sport injuries of the ankle and foot. I would like to mention before this, we are publishing a book, both Dr. Muhammad Rashid and myself, which would include questions and answers as we would be asking in the board. And the next, not this coming next week, the week after, we will be discussing all these conditions in the lecture. Okay, there will be 50 topics which will be covered during the 3 hours. That is, if Dr. Khalid agrees to it. Now, what we will be talking about this week would be included in this outline. First of all, we will be talking about non-union and malunion of the clavicle, neurovascular injuries in the clavicle fractures, brachial plexus injuries, vascular injuries, post-traumatic osteoarthritis of the acromioclavicular joint, infection following fixation with clavicle fractures, complications of intramedullary fixation, acromioclavicular joint injuries, ankle and foot sports injuries, which includes ankle injuries, lateral ankle injuries, medial ankle injuries, syndesmosis, osteochondral lesions, ankle impingement syndromes, anterior bony impingement, posterior bony ankle impingement, soft tissue impingement, heel pain, and plantar fasciitis, Lisfrank's injuries, turf toe. In addition, we will also discuss sesamoid disorders, stress fractures, fifth metatarsal fractures, etc. until the end. I hope we will be able to cover all these topics by the end of 3 hours. Now, speaking about the clavicle and non-union and malunion. Non-union of the clavicle is defined as the lack of radiographic healing at 6 months post-injury. Initially thought to be an uncommon complication, as at that time they found that it was less than 1%. But nowadays, we are noticing more and more incidences of non-union of the clavicle when treated conservatively. This is a displaced mid-shaft clavicle fracture, and this was managed conservatively. You can see in the X-ray in the middle that there is a non-union where the surgeon ended up putting a plate and autograft so as to obtain a union. When you get non-union of the clavicle, it's not always innocent, because the position of the fragments might cause pressure on the brachial plexus. It might cause pressure on the vessels, and the patient's function won't be normal of the shoulder because the glenoid is no longer facing in the normal position. So you have to think of this point. So these three conditions are enough to tell you in cases of severely displaced fractures, in cases of severely comminuted fractures, consider open surgery. Non-union of the clavicle fractures are said to be more common than what was mentioned in the previous situations. Studies suggesting up to 15% rate of non-union for all clavicle fractures, and an even higher rate for fractures of the lateral end of the clavicle. It goes from 18 to 40%. So, as orthopedic surgeons, think of these points, think of the indications, think of the warning signs that I'm giving you to consider when you should operate and when you would treat the patient conservatively. According to Robinson, he looked at 868 patients and found a non-union rate of 6.2%, but increased if fracture was displaced or comminuted, and the rate went up to 21%. I'm telling you this so that you'll keep this in your mind, that the fracture of the clavicle is not innocent. The risk factors for non-union include increasing age, the female sex, fracture displacement, comminution, and smoking. Non-union of the lateral end of the clavicle fractures may be asymptomatic, especially in the elderly, but the majority of midshaft non-union occur in young, active individuals. These will be symptomatic and enough to require treatment. Along with some of the discomfort or pain the patient may have, first, a clicking sensation that bothers them, especially in young girls, restriction of shoulder movement, weakness, a cosmetic deformity, and the clinical and radiographic signs of non-union include mobility, pain on stressing of the fracture, and absence of bridging callus on radiographs. Wijndijk et al. Concluded that non-union rates were less than 10% following plate fixation of the clavicle fracture. The COT study found a significant difference in the rates of non-union, with 2 out of 62 in the operative group versus 7 out of 49 in the conservatively managed patients. Meta-analysis of 13 studies reported the pooled results of non-union incidents, and they presented a significant difference favoring operative over non-operative treatment. The surgical treatment for a midshaft non-union of the clavicle is open reduction and internal fixation with a pre-contoured anatomic clavicle plate with the addition of iliac crest graft or an osteoinductive bone graft substitute. If the non-union is hypertrophic, uncommon, then the morselized autograft from the local bone is applied to the non-union site. You can see the plate of how well it's contoured around the clavicle. It's not really very solid in this X-ray, but with time, it looks like it's going to heal. You need definitely an autograft. More commonly, it is an atrophic non-union with loss of bone length. When you have a loss of bone length, the whole function of the shoulder changes. In this case, a structural or intercalary graft consisting of tricortical iliac crest autograft may be required in such cases where there has been excessive loss of length or failed previous surgery. What about malunion? Again, it's not innocent. All displaced fractures that are treated non-operatively heal with some degree of malunion due to angulation or shortening. Think of it, angulation or shortening. But they seem to be asymptomatic. But there are quite a number who are complaining of problems of shortening, weakening, malposition of the glenoid surface with respect to the head of the humerus. They complain of overhead throwing. So you have so many problems. It was believed that malunion of the clavicle was of radiographic interest only, and clinically the fractures were deemed to have healed. We were so happy, but we had a malunited fracture. We had a glenoid in malposition. We had a weakened shoulder. We had in appearance a shoulder which is shorter than its contralateral side. Think of it, fellows. Look at, in this case, there's shortening of more than 2 centimeters. More than 2 centimeters. Look at the displacement. This displacement. You have the thoracic outlet in the area. You have the veins, you have the nerves. All these might become under pressure. You have the glenoid surface changes. Don't forget this. However, more recently, several investigators have described a fairly consistent pattern of patient symptomatology following malunion of displaced mid-shaft fractures of the clavicle. Hill et al. Found that 31% of patients described unsatisfactory outcomes after non-operative care of displaced clavicle fractures. He spoke about shortening of greater than 15 millimeters or 1.5 centimeters is associated with shoulder discomfort and dysfunction. It has been suggested that the angular deformity and the shortening change the orientation of the glenoid, altering the shoulder dynamics. So, what does it also cause? It causes pain. It can cause symptomatic paresthesia of the arm and hand due to pressure on the nerves. With loss of strength, they will complain of numbness at times. They have problems while sleeping. One scapula becomes more prominent than the other. There's a change in position of the scapula so that the patient won't sleep comfortably on his back in the supine position. And of course, especially in girls, due to cosmetic complaints. Also, men usually complain of. It is suggested that a shortened lever arm of the shoulder girdle changes the orientation of the glenoid with winging of the scapula, which leads to functional problems of the shoulder in overhead movements. Shortening of the clavicle has a negative effect on muscle tendon tension and muscle balance. You should know that there are around 18 muscles around the shoulder joint. The length of these muscle tendons has changed, which may result in loss of strength and endurability. And this can be measured in patients with short malunion. The malunion results in a changed load of the acromioclavicular joint also, and sternoclavicular joint. So you have three joints which are disturbed. Reported acromioclavicular joint arthrosis in patients after follow-up of malunited clavicular fractures have led to this, is a result of this due to malposition. Biomechanically, it changes. Chan et al. Suggested that malunited clavicle fractures that has united with deformity or shortening may have an adverse effect on the normal shoulder girdle function. So you see, all these investigators are arriving to the point to say that malunion is bad, shortening is bad, angulation is bad. Try and avoid this by doing the proper surgical indication. They reported that a malunited fracture of the clavicle was believed to be a contributing factor to shoulder girdle dysfunction. In each patient, the functional status of the involved limb was improved after corrective osteotomy at the site of the deformity. Realignment and plate fixation improved the condition. Treatment can either be prevention in the acute phase by means of primary fixation of displaced clavicle fracture, or later, when the symptomatic malunion is established, a correction osteotomy with or without an iliac crest autograft can be performed. Several reports on the operative treatment of malunited clavicular fractures have been published, with all of them reporting good results and satisfied patients. Of course, major complications like bone healing problems and deep infections requiring implant removal were reported at a rate no higher than 7%. You have to be aware that you could have complications. You could have problems when you don't do a proper fixation. You could have problems when you have poor indications. So keep this in mind. Reported rates for minor complications, such as wound infection and implant irritation that could be resolved without further surgery, were as high as 31%. What about the neurovascular injuries in clavicle fractures? Look at this slide. Look where the nerve is. Look where the vessels are. They are just behind. They are quite close. And this is something you have to observe. Neurovascular injuries associated with clavicle fractures are relatively uncommon despite the proximity of the brachial plexus and subclavian vein. Sorry, okay. These injuries, complications, can be acute presentations and delay presentation or iatrogenic. I want to see, there's somebody calling me. Okay. Acute neurovascular injuries, I've taken it from Dr. Brahim's lecture, and I'm very pleased to indicate one should check for and do a proper examination. He should check for possible neurovascular deficits at the very beginning, especially for brachial plexus injuries. And he should be aware that the neurovascular bundle is very, very, very close to the clavicle. The subclavian vessels are about 1 centimeter from the clavicle. And this slide shows it. You see the vessels and see where the fracture site is. You can injure any of these vessels either from the fracture or from the surgery due to proper insertion of instrumentation. Direct injury to the vessels and brachial plexus can occur at the time of the fracture. A thorough neurological and vascular examination should be carried out in suspected cases, especially clavicle fractures associated with high energy trauma or polytrauma patients, where other injury could cover up for it. One should not miss these injuries, the neurovascular injuries. If there is suspicion of a vascular injury, then an urgent angiogram or CT angiogram need to be arranged. A vascular surgeon may need to be informed when the index of suspicion is high. There have also been case reports of direct neurologic injury from clavicular fracture fragments. In this situation, operative decompression of the brachial plexus by reduction and fixation of the clavicle fracture is indicated. This shows you further. You see, in my practice, we used to do, in cases of simple fractures, not comminuted, I routinely would put the plate on the superior aspect of the clavicle. But in cases of complicated cases, I would put my plate on the anterior aspect to get the penetrance of screws further from damaging the vessels. So these are two ways. But at times where the fracture is too comminuted, I've even put two plates to fix the clavicle. Delayed neurovascular injuries do occur. And this occurs from scar tissue around the scalene muscles. You know, all these nerves pass between the scalenus medius and scalenus anticus and between the clavicle and the first rib. When you have a fractured clavicle, it could form a huge amount of callus. There can be a large amount of scar tissue, and with time, you have a delayed neurovascular damage. A number of synonyms have been applied to this condition, including the thoracic outlet syndrome, the costoclavicular syndrome, and fractured clavicle rib syndrome. Keep these in mind. And this shows you the scalene muscles, shows you the nerves passing in between it and the vessels. in between the clavicle and the first rib, and the space, the thoracic outlet, will become less in size, and you will end up having a thoracic outlet syndrome. This is said to occur when there is entrapment of the medial cord of the brachial plexus by callus superiorly by the first rib inferiorly, producing predominantly in ulnar nerve symptoms. And this situation is more likely in the presence of hypertrophic non-union or malunion. Rao reported late neurovascular sequelae, 2 out of 690 fractures. That is 0.3%, although higher rates have been reported in more recent studies. A diagnosis is made when a patient has a suggestive clinical history with supportive evidence on electrophysiologic testing. The treatment should be directed toward correction of the malunion or non-union. McKee reported resolution of thoracic outlet syndrome symptoms in 16 patients who underwent corrective clavicular osteotomy to treat a malunion. What about iatrogenic injuries? We are causing injuries. Brachial plexus injuries. Iatrogenic neurovascular complications are rare. The incidence of brachial plexus injury is reported to be 0 to 1.5%. It is postulated that this traction of the fracture site and the delayed surgery several weeks after their injury can lead to a traction injury of the brachial plexus, especially if you have shortening and you're trying your best to lengthen the fracture back to normal. Patients with a significant brachial plexus injury following clavicle fracture surgery have a characteristic presentation of, number one, unremitting radicular pain. They would have an increased amount of pain. They will have profound weakness and sensory loss in the immediate post-operative period. The lesion is usually incomplete, with the upper trunk and suprascapular nerve most commonly involved. Recovery from post-operative brachial plexus injury occurs over many months, and the final outcome is variable. All 3 cases following intramedullary fixation reported by Ring and Holovax were managed non-operatively and had complete resolution of symptoms within 6 months. Significant post-operative plexopathy has severe symptoms and a variable outcome. Therefore, urgent revision surgery, including the support of a brachial plexus surgeon as neurolysis, repair, transfer, or grafting may be required. What about vascular injuries? In a meta-analysis of 382 cases, I think, let me see, because I have a problem over here. Hey, in a meta-analysis of 582 cases of clavicle fixation, all 11 studies did not report a vascular complication. Arterial injuries are rare and are usually pseudoaneurysms associated with prominent screws. So I tell you, fellow residents, beware of the length of your screws. Do a proper measurement. Put the exact length. Don't say it's better to have a longer screw than a shorter. Always aim at obtaining the exact length. These may be clinically silent for several years before presentation as subcritical upper limb ischemia. So you have to pay attention. If you look at this fellow had a fracture, a simple fracture as a matter, the cleft, where a straight plate was applied. And you see that one of the screws was long. This patient presented with a pseudo aneurysm. You have to pay attention. Look at this screw. The other screws aren't bad. This screw went right and irritated and injured the wall of the vessel. They usually present as late upper limb claudication between 2 years and 10 years following surgery, or may present as an acute deterioration to limb-threatening ischemia as a result of emboli to the upper limb. The pseudoaneurysm can be diagnosed by an angiogram. Treatment usually involves removal of the implant and a vascular stent or graft procedure by the vascular surgeon. Venous injuries are a result of tearing of the vessel wall by fracture manipulation, drills, or implants. Keep this in mind. Once the injury is diagnosed, the two main goals are to gain rapid control of bleeding and prevent air entering the circulation. An urgent vascular review should be sought for surgical repair of the subclavian vein that may require grafting. Clavicle fractures with a high risk of iatrogenic injury include the medial fractures, a grossly comminuted fracture, a fracture with over 2-week delay from the time of injury, or non-union, malunion, and revision cases. To avoid significant iatrogenic neurovascular injuries, the surgeon must have a detailed understanding of the neurovascular anatomy of the region. Not anyone to go ahead and do the surgery. My advice as being an elderly surgeon, I wouldn't let a junior surgeon operate on a comminuted fracture of the clavicle, unless, first of all, he's well-trained on how to insert the screws, well-trained on how to measure the screws, well-trained on where to insert his drill hole. All these are important. Once he gets these, he can do as much as he wants. But if he's junior and has no experience and does not know the anatomy, I won't let him do it. All dissection around the medial and inferior clavicle should be performed in the subperiosteal plane. You should not go deep beyond. Screws should be placed along a safe trajectory, and screw lengths should be accurately measured. What about refractures? Refracture, the non-operative treatment, is uncommon. That's why some surgeons prefer to do it. With increasing popularity of operative fixation of the clavicle fractures and subsequent implant removal, there is a trend. There is a trend towards a re-injury following a new episode. And this is embarrassing. Once you've removed the plate and you have done the previous surgery and the clavicle has healed, it is embarrassing to have a refracture. You should warn the patient at all times. You should keep them in the picture. They should know what is going on. Okay? So, re-injury shortly after operative treatment may cause breakage or bending of the fixation device because you have used the improper fixation, you have used improper instrumentation to hold and position the plate in the proper place, or the fracture around the implants. Non-union is relatively common after refracture, and the internal fixation is often required. Again, so to repeat this, beware of whatever you're using, whatever technique you are using, because all this reflects on the incidence of non-union. Be aware of the fracture comminution. Include the patient in the treatment plan. Let him know that there is such complications that could occur. This would save you problems in the future. I have included several complications. One is a plate, which is fractured. You can see it's broken. And at the site, this was a comminuted fracture. You see that there is a gap between the clavicle. You have to use an intercalary graft. And with Anna, in these cases, I usually apply 2 plates, one superior and one anterior, at right angles to each other. This is another comminuted fracture. You can have non-union, you can have improper fixation. And the surgeon decided to insert this intramedullary nail with locking at the distal end. And what happened? The screw broke. So you should be aware of all these points. And the patient has formed a large amount of bone around it, which tells you that this was moving for some time. It was loose, and the fragment was not very stable. You know, material, plate, screws, bear stress for some time. But there is a race between healing a bone and failure of the plate and failure of the intramedullary device. So keep this in mind. One of the complications of fractures of the clavicle is post-traumatic osteoarthritis of the acromioclavicular joint. This complication occurs most frequently following intra-articular fractures of the lateral end of the clavicle and may be seen after an extra-articular fracture that is treated with a hook plate. The hook plate, you should use the proper size. You should know how to use it. And you should remove it at the proper time because this causes a constant irritation and there will be failure, either fracture of the acromion, fracture or pull out of the plate. Keep this in mind. In a medium-term study of 101 lateral end clavicular fractures, 3 of 11 intra-articular, which type is the Edinburgh, we spoke about it last time, type 3B2, fractures, and 6 of 90 extra-articular fractures. They were associated with radiographic signs of osteoarthritis. The major symptoms is activity-related pain, which characteristically is worsened by cross-arm adduction. Symptomatic osteoarthritis of the acromioclavicular joint may be treated with excision of the lateral end of the fragment. But this is not the solution if you don't know how to do it. This is not the solution if you don't know how much you do remove of the clavicle. If you remove more than a half a centimeter, you are creating an instability in the anterior posterior position. And this in itself would give the patient problems. So you have to know how much to remove, when to remove. Infection following fixation of clavicle fracture. Infection following fixation of clavicle fractures has shown reduced rates in recent times following improvements in surgical technique with better soft tissue handling. Two-layered closure of the wound. You have to do a proper closure. Be over or studious to the resident below you if he has no experience in the closure of wounds. They should close them layer by layer and biomechanically. This is far better, superior to give us a stable wound, a stable fracture, and use of perioperative antibiotic prophylaxis. So we believe in stability. We believe in proper closure and proper antibiotic prophylaxis. Zlowski reported a superficial infection rate of 4.4% and a deep infection rate of only 2.2%. These figures are significantly improved compared to earlier studies. Superficial infections are often treated with oral antibiotics with good results and seldom require implant removal. Deep infections should be treated initially with intravenous antibiotics for a certain period following discussion with the microbiologist, followed by oral antibiotics. It should be totally in agreement with the microbiologist. They should join up with the treatment in deep infections. The implant is removed in cases where the fixation is unstable. We believe in stability. Implant has loosened or there are few or no signs of healing occurring. The implant is removed along with a thorough debridement of all infected and dead tissue, but not the vessels, not the neurovascular structures. Be careful. Including bone, which is infected, you can remove it. All tissue which is infected, you can remove it. Then, with the coverage with antibiotics, once he heals, and if he is for sure healed, then you can redo this surgery. Antibiotic impregnated cement may be placed in the residual space. A delayed surgery is then performed with or without bone graft to replace the bone loss. Plastic surgery support may be required to provide soft tissue closure in the form of local rotational flaps or free flaps, because many times you will end up with dead space after you have removed all scar tissue, and you have to graft it. Okay, be careful. What about complications of plate fixation? Following plate fixation of the clavicle fractures may require another surgery to remove or revise the plate. Such major complications include non-union, symptomatic malunion, deep infection. We spoke about these. Mechanical failure, irritation due to the implant, which requires plate removal, breakage of the implant, angulation, and refracture after plate removal. So be careful. And iatrogenic neurovascular complications, as I mentioned, are rare, but they do occur. Due to the subcutaneous nature of the clavicle, local irritation from hardware prominence is relatively common, and the incidence of hardware removal following a fractured clavicle treated surgically is from 5 to 100%. A meta-analysis of plate fixation of the clavicle fractures reported that the vast majority of complications seem to be implant-related, with irritation, failure of the plate. I'm repeating these so that you'll keep them in mind. Non-union, malunion, all these occur. They are improperly done, improperly followed up, improperly immobilized, improperly promoting what type of physiotherapy the patient should have following the surgery. Also, improper closure of the wounds. Don't forget they could have infections. Don't forget about the injuries of the vessels following surgery. Intramedullary fixation, you have to know that they are higher than plate fixation. This is all what I want you to know. And you cannot use any material intramedullary. Don't forget about migration of pins, of rods. I have removed a pin from the spinal cord. I have removed one from the pleural cavity. So you have to keep this. This was at one time quite popular for fractures of the outer end of the clavicle. So you have to keep this in mind. So the conclusion about clavicle fractures are common upper extremity skeletal injuries. Most patients with clavicular fractures can be effectively treated conservatively in a sling for a period of immobilization to allow initial healing following structured rehabilitation. These are in the simple fractures. In the fractures that have no shorten, in the fractures that have no significant angulation or comminution. So keep this in mind. We like to operate. We like to regain the length of the clavicle. There is now good evidence that a subset of patients, the young, active, healthy patient with a completely displaced clavicle fracture over 2 centimeters, I mentioned this, that usually we prefer to operate. Now we come to our other topic, acromioclavicular joint injuries. Are there any questions so far? Khalid, am I clear?
واضح جدا دكتور.
Okay. Now we're going into acromioclavicular joint injuries. The acromioclavicular joint is a diarthrodial joint in association with the sternoclavicular joint. It connects the arm with the axial skeleton. Injuries of the acromioclavicular joint were initially described by Hippocrates in the 4th century BC. They are common in contact athletes and they represent 40 to 50% of all sport injuries of the shoulder. Proper treatment is important, as failure may result in aesthetically unpleasant deformities of the clavicle, pain, fatigue, and muscle weakness, especially with overhead activities, especially with overhead activities. Dysfunction of the scapulothoracic dynamics. Why? Why? If you have a dislocation, what happens? The scapulothoracic change in position. The dynamics is changed. The position is changed. The function of the muscles change. And as a result of a significant dislocation and unfortunately, controversies still exist on the classification and further treatment of these injuries. You should know that you have the clavicle, you have the coracoid process of the scapula, and you have the acromion. Between the coracoid process and the acromion, we know that is the coracoacromial ligament. Between the coracoid and the clavicle, you have the trapezoid, which is most lateral, and the conoid ligaments. These give us superior stability of the clavicle. And anterior and posterior of the acromioclavicular joint are thickenings of the capsule, and these stabilize the acromioclavicular joint in the anterior and posterior position. Of course, you have the muscles, the trapezius, you have the pectoralis, you have all the muscles that insert on the clavicle together with their fascia produces also further stability of the acromioclavicular joint. The acromioclavicular joint is formed by the medial facet of the acromion and the lateral aspect of the clavicle. It has variable angles of inclination, variable angles of inclination. And this is where Bigliani's classification also comes. The acromion can be straight, slightly angulated, or beaking distally. So these have an effect, we believe, on the rotator cuff. Some don't believe it to be so. So it has variable angles of inclination in both the sagittal and coronal planes, ranging from a vertical orientation to 50 degrees of obliquity. The articular surface of the acromion and of the clavicle has hyaline cartilage until 17 years of age. They have hyaline cartilage only until the 17 years of age when it transitions to fibrocartilage. This is a question I usually like to ask. At what age does the acromial end of the clavicle quit having hyaline cartilage? It's at the age of 17 years, which shifts to fibrocartilage. A similar evolution occurs at the clavicular side of the acromion, which had hyaline cartilage, and then it changes to fibrocartilage, but at a later age, at the age of 23. An acromioclavicular joint meniscus also exists, has been described, but its biomechanical role is poorly understood. We have a meniscus, but its role is poorly understood, and it undergoes an involution process with aging and completely disintegrates by the age of 40. This may explain why degenerative changes affect this joint more frequently than the sternoclavicular joint. This shows you it further. Look at the yellow, which is the conoid, the trapezoid, and look at the orange, which is more medial, is the conoid ligament. It is present in between the coracoid and the inferior tubercle of the clavicle. And this holds it. It maintains it in the vertical direction. Look at the ligaments about the clavicle and the acromion. Look at the coracoacromial ligament, which is present over here. This is the acromioclavicular ligament. All these promote stability of this joint, and it is involved in holding the upper extremity with respect to the whole axial spine and the body. Although the AC joint is particularly stable, it can undergo up to 6 millimeters of translation in the anterior, posterior, and superior directions under a load. 6 millimeters, remember, 6 millimeters. The joint rotates 5 to 8 degrees with the scapulothoracic motion and 40 to 45 degrees with shoulder abduction and elevation. These motions are important to know. You have to know hand in hand the motion of the shoulder joint with the motion of the acromioclavicular joint with motion of the scapula. All these are important to know. You have to know that there is acromioclavicular motion as a whole around 6 millimeters between the anterior and posterior directions. You have to know that the clavicle, when it's functioning, it runs like a cone. It is rotating, it is elevating, it is moving in the anterior and posterior direction. The center is the sternoclavicular joint. Stability of the joint is provided by passive ligaments and active restraints of muscles. Ligaments have been divided into intrinsic. The intrinsic ligaments are the acromioclavicular ligaments and the capsule itself. We said that the anterior and posterior acromioclavicular ligaments are nothing but thickenings of the capsule. And we spoke about the extrinsic ligaments, which include the coracoclavicular ligaments, namely the trapezoid and the conoid. Don't forget these. Anterior posterior plane stability is provided by the acromioclavicular ligaments, which are thickenings of the joint capsule. Normal acromioclavicular ligaments are about in thickness. It is a thickening of the capsule. So this shows you the various ligaments. It tells you, don't forget, hey, disc, I am a disc present only temporarily between the acromion and clavicle. Tells you that you have a coracoacromial ligament. You even have a coracohumeral ligament, but we won't be talking about this. And don't forget about these trapezoid ligaments. The superior part is the strongest and is further augmented by merging fibers of the deltoid trapezial fascia. These exist because these muscles insert on the clavicle and the spine of the scapula. So you have to think of it. They give additional support to these joints. The acromioclavicular ligaments also act in the horizontal plane, providing 50 to 90% restraint to the anterior and posterior displacements, respectively, as I have repeatedly mentioned. The anterior or superior portion of the capsule may also play a role in preventing posterior displacement of the clavicle. And the anterior and posterior area likely acts as a restraint to posterior rotation. The acromioclavicular capsule attachments extend approximately, don't forget this, the acromioclavicular capsule attachments extend approximately 5 to 8 millimeters from the joint onto the adjacent bone. Therefore, excessive, that's what I was mentioning before, excessive distal clavicle resection may result in increased posterior translation and rotation of the clavicle, and this should be avoided. Don't. The maximum amount you are allowed to remove from the clavicle is 5 millimeters. Don't remove more, because otherwise you might create an instability and make the patient worse than what he was. This is for osteoarthritis, when you want to resect the outer end of the clavicle. The superior-inferior stability is mainly provided by the coracoclavicular ligaments. The trapezoid ligament is the most lateral. It originates on the lateral aspect of the undersurface of the clavicle. And if you measure its length from the coracoid to the clavicle, it is 25.4 millimeters in males and 22.9 millimeters in females. And it provides resistance to acromioclavicular joint compression in the vertical direction, vertical inferior direction. The conoid ligament insertion is more medial, but it's longer, 47.2 millimeters in men and 42.8 millimeters in females. It is responsible for about 60% of the restraint to anterior and superior clavicular displacement and rotation. Coracoclavicular ligaments have a major role in stabilizing the joint against greater forces, whereas acromioclavicular ligaments are more effective against smaller loads. The deltoid and trapezius muscles contribute to joint stability through their insertions on the superior aspect of the clavicle and acromion process. Epidemiology and classification. Acromioclavicular joint injuries are common in contact sports. However, the real prevalence is likely to underestimated as the diagnosis is missed in several patients. We miss them. Webb and Bannister reported a 45% incidence of acromioclavicular injuries in first-class rugby players. The spectrum of acromioclavicular joint injury can range from minor sprains and subluxations to complete dislocations. The injury is often caused by a direct trauma to the shoulder. The patient, the individual, the candidate falls directly on the shoulder with the arm in adduction, as I've shown you in a previous slide. This is showing them. This is another slide. You see on the right-hand side, his shoulder is nearly in the adducted position, flexed. Now, if they land on the shoulder in this position, they could have an acromioclavicular joint dislocation due to this direct fall or fall from a bicycle. The acromion is then pushed inferiorly, while the clavicle holds its anatomic position by resisting downward displacement through an interlocking of the sternoclavicular and coracoclavicular ligaments and anteroposterior displacement through the acromioclavicular ligaments. The endpoint of this mechanism is variable damage to the intrinsic and extrinsic ligaments. In the worst case scenario, high energy trauma can result in avulsion of the deltoid and the trapezius muscles attachments from the clavicle. Less frequently, the injury is caused by an indirect force. A fall onto the elbow can drive the humerus proximally, involving the acromioclavicular joint. However, in these circumstances, the strain only affects intrinsic ligaments and not the coracoclavicular ligaments. The extent of the clavicle displacement varies based on the severity of the injury. Let's go back to Rockwood. In 1984, he developed a six-stage, which we still respect, radiographic classification of the acromioclavicular joint injuries. Type 1 is a sprain of the joint with no involvement of the intrinsic and extrinsic ligaments. Type 2 injuries is an acromioclavicular ligaments are usually torn, while the coracoclavicular ligaments are sprained, and displacement is usually less than 25%. You can hardly notice any displacement. This tells you about Rockwood's classification. We have a problem in deciding what to do in type 3, where all the ligaments are torn, but there's no significant displacement. In type 4, all the ligaments are torn, and the clavicle has migrated superiorly and posterior into the trapezius muscle. Type 5, all the ligaments are torn, and the clavicle has migrated vertically, while type 6, the clavicle is pushed downwards underneath the coracoid process, and all the ligaments are torn. This is the Rockwood classification that is used. So, Rockwood classification, soft tissue injury, radiographs. Type 1, we spoke about it being a sprain, and the radiographs appeared normal. Type 2, we spoke about the acromioclavicular ligament torn. The coracoclavicular ligaments have undergone a stretching but no tear, and you have the coracoclavicular ligaments are displaced less than 25%. And type 3, you have all ligaments are torn, and the displacement is between 25 and 100% when you compare it to the contralateral side. And finally, type 4 is all and displaced posteriorly within the trapezius muscle on axillary views. Type 5 is all ligaments are torn, and the displacement is more than 100%. And type 6, the clavicle is displaced inferiorly in a subcoracoid, subacromial position, and all the ligaments are torn. This shows you it further. I don't want you to forget this classification, because this we still use, and it helps us a lot in the decision making, what type of surgery, if the patient needs surgery. A disruption of the coracoclavicular ligaments, the acromioclavicular ligaments, and the sprain of the deltopectoral fascia define type 3 injuries. And this is 25 to 100% displacement. This shows you a type 3, but this is a problem because it's not so elevated, not so subluxed or dislocated, and what to do, treat conservatively or surgically. So we mentioned about all these, and this shows you a type 4, which on axillary views tells us that the clavicle is within the trapezius muscle and displaced posteriorly. And this shows you a type 5, where the clavicle is vertical, the coracoclavicular ligaments are torn, the acromioclavicular ligaments are torn completely. So don't forget these classifications. Okay? This is a type 6, where the clavicle lies beneath the coracoid process and it's torn. The coracoclavicular ligaments are torn and the acromioclavicular ligaments are torn. Clinical presentation and imaging, the majority of patients with an acute acromioclavicular injury will present with localized pain, swelling, and tenderness over the joint. The injured upper extremity is typically held in an adducted position. You see the patient coming to the emergency room, having his hand of the opposite side beneath the elbow, with the elbow flexed to reduce the pain. Pain can be accentuated with abduction and cross-body adduction of the arm, which load the acromioclavicular joint. Standing examination may increase the extent of the acromioclavicular joint displacement. In type 2 and 3 injuries, reduction of the acromioclavicular joint is possible when a downward pressure is applied on the lateral aspect of the clavicle. This shows you how the patient comes into the emergency. He keeps his arm in adduction with support, Sternoclavicular pain may also be present, especially in type 4 injuries. Why? Because the whole clavicle is moved posteriorly. So you can imagine the amount of strain on the sternoclavicular joint. When posteriorly displaced, the distal portion of the clavicle is associated with anterior dislocation of the sternoclavicular joint, with stress on that joint. Therefore, they would have pain. Patients with type 5 and type 6 injuries may claim of pain in the neck. Why? Because they're displaced, so markedly displaced, and strain on the trapezius muscle. As a result also of soft tissue injury and stripping of the deltotrapezial fascia. Transient paresthesias of the arm have been reported in type 6 dislocation. Clinical diagnosis is confirmed with imaging analysis. Standard X-rays should reduce the exposure of a standard shoulder radiograph by 1/2 to maximize the visualization of the AC joint. Standard radiographs include a true anterior, posterior, and lateral views, axillary views. So anterior views, anterior, like the Gracie view, true AP view, and axillary views, like the West Point view, or having the patient hold on any structure, holding the arm externally rotated and supported by a venous pole, and then shoot your X-rays through the armpit with a cassette posteriorly, will give you a true axillary view and tell you the position of the clavicle. Also, in addition, one could use a Zanka view, and this is recommended to increase visualization of the joint, directing the X-ray beam to 10 to 15 degrees cephalic tilt and allows for contralateral comparison for the coracoclavicular distance. You can see it. This is a bilateral Zanka view. We don't use any longer weights. We found that it's useless because as the patient is carrying weights, he's making use of his muscles, and this would affect the amount of displacement. So we prefer not to use weights anymore. So we take a Zanka's view with a 15 degrees tilt. The axillary view or lateral stress X-ray, like the Alexander view, are essential to diagnose posterior displacement of the clavicle in type 4 and 5. Acromioclavicular joint separations. The coracoclavicular distance should be measured on the anterior posterior view. Look, this is several views that we like to take. Okay, we have a true AP view. We can take a Zanker's view. Can do a Gracie view. And you can use this view. This is, I think it's the Alexander view. Also, these are many views that we take of the acromioclavicular joint. This tells you where the axillary view helps us in telling us where the clavicle is with respect to the acromion. Is it anterior, posterior, or superior? Now, you have to be aware and well acquainted with these physical findings due to subacromial impingement. You have to know how to do the Neers test. You have to know how to do the Hawkins test, the rotator cuff tear, the drop-on test. It cannot support the arm. The subscapularis is well demonstrated on the belly press test and the lift-off test. And you have abduction, external rotation test, the infraspinatus and the supraspinatus is the Jone test. Please, this slide is very, very important so as to be aware of all these tests if you want to deal with the shoulder. In healthy subjects, the acromioclavicular joint is congruent and the coracoclavicular distance is between 1.1 and 1.3 centimeters. A 40 to 50% difference in the coracoclavicular distance between the normal and the affected shoulders is predictive for a complete disruption of the coracoclavicular ligament. Rockwood et al. Found a side-to-side coracoclavicular difference of 25% in cases of complete AC joint involvement or disruption. Additional imaging, including MRI, are helpful in assessing acromioclavicular and coracoclavicular ligamentous disruption. Moreover, magnetic resonance imaging can be helpful in detecting associated injuries requiring surgical treatment. Approximately 18.2% of patients with grade 3 to 5 AC dislocations show an additional injury requiring surgery. Correct management depends on the grade of the AC joint injury and timing. Conservative treatment with a sling has been shown to be successful in type 1 and type 2 sprains. Additional options include simple analgesia, anti-inflammatory medications, ice therapy, activity modification, and complete rest. Immobilization is usually shorter in type 1 injuries than in type 2 sprains, as reported by Park et al. The sling should be discontinued once the patient is asymptomatic. Contact sports and heavy lifting should be avoided until the patient is free of pain and has symptomatic shoulder range of motion and strength. Despite patient satisfaction rates of 80 to 90%, persistent pain at the acromioclavicular joint with limitations of activities may have been described. However, the rate of patients with persistent pain decreases with time and is lower in type 2 than in type 1 injuries. In the treatment of type 3 dislocations, it is still debated. Both conservative treatment and surgery have been proposed with satisfactory outcomes, and no statistically significant benefit from surgery has emerged. Schlegel compared the range of motion and rotational strengths of conservatively treated shoulders with the contralateral side and found no differences. Gamina reported scapular dyskinesis at a rate of 70.6% and the sixth scapular syndrome at 58.3% after conservative treatment of type 3 injuries. Although similar outcomes have been reported, surgical treatment is still preferred in young and active patients. The goal of surgery is to report or restore anatomy and prevent hypermobility in horizontal, vertical, and rotational planes without limiting the physiological acromioclavicular joint with regard to scapulothoracic motion. Multiple surgical options have been described to address the acromioclavicular joint injuries. Primary fixation of the AC joint, fixation of the clavicle to the coracoid, ligament reconstruction, coracoid process transfers, distal clavicle resection. Primary fixation of the AC joint has been the treatment of choice for several decades. However, severe complications have been reported with fixation devices such as K-wires migrating to the thorax. This is a patient that was operated and they used fixation wires. They even bent the out end of the wires. Seems that the surgeon didn't bend one of the wires, and the wire went way into the spinal cord of the cervical spine. You see that the wires are present through the foramen, the neural foramen, the intervertebral foramen, into the spinal cord. Hook plates were proposed with satisfactory results in combination with or without soft tissue augmentation. However, plate failure or dislocation, persistent pain, and infections have been reported. Coracoclavicular fixation with screws was initially popularized by Bosworth. This is the hook plates. You have to use the proper size, proper screws. This was a very bad indication, not the proper size, and not the proper method of fixation was used. This is a Bosworth screw put from the clavicle into the coracoid. You have to widen the hole of the clavicle so that the screw does not hold tightly, and use a partially threaded screw so as to create some sort of compression. Many times these screws were pulled out or broke, or there has been an insufficiency fracture at the level of the drill hole. This technique was usually associated with corticoclavicular ligament reconstruction in acute cases in the case of the hooked leg. Recent advancements in synthetic loops and arthroscopic techniques has renewed interest in this surgical option. There are several advantages of loops over screws. First of all, they don't break, but it has a disadvantage. If you make a hole through the clavicle in an improper direction or improper distance, this creates a zone of weakness, and the patient can have a fracture at this zone. And it gives us only stability in the dorsal ventral direction, not in the anterior posterior direction when you use a loop. This is a loop from the coracoid process to the clavicle. This is good for vertical, but not anterior posterior. Most important loops do not need to be removed. They are a less rigid construct, and their position can be adjusted to achieve a more anatomic reduction and reduced fracture risk. Major drawbacks of loops include clavicle osteolysis, suture cutout, and foreign body reaction. This technique is effective in acute cases when the healing potential of soft tissues, such as the corticoclavicular ligaments, is maintained. In chronic cases, the loop must be reinforced with ligament transfer, such as the coracoacromioclavicle, such as in the technique done by Weaver and Dunn, which I will be discussing soon, in ligament reconstruction. AC, acromioclavicular ligament transfer, that increases the stability of the acromioclavicular joint, was initially described, imagine, in 1913 by Cadena. However, the technique was modified and popularized by Weaver and Dunn, who described a transposition of the coracoacromial ligament in association with the distal clavicle resection to prevent the risk of joint degeneration. I hope I have a diagram over here. Yes, this tells us about it. You see, in this case, we have a tear of both the trapezoid and conoid. And if you look at the coracoacromial ligament has been detached, and it has been with a small fragment of bone off from the acromion, and this is passed through a tunnel in the clavicle. So you have a loop to substitute for the trapezoid and the conoid, and you have the coracoacromial ligament transferred and inserted through the intramedullary cavity of the clavicle. The whole purpose of this is that the loops that we are using for the trapezoid and conoid supported in the superior inferior direction, and the coracoacromial ligament, which is transferred in this view, is used for anterior and posterior stability. One alone is not enough. The coracoacromial ligament was detached from the acromion and fixed to the lateral end of the clavicle. Primary fixation could be increased by preserving some bone at the end of the coracoacromial ligament. As I mentioned, you leave some bone attached to it. Primary stability was also increased with the corticoclavicular loops. Recently, a similar procedure has been described within all arthroscopic approach. Different autografts and allografts, including semitendinosus and tibialis anterior, and different looping configurations have been described to increase the stability of the joint in different planes. One potential drawback of techniques involving different tunnels through the lateral clavicle and coracoid is their potential osseous weakening and increased risk of fracture. Coracoid transfer was introduced by Dewar and Barrington for acute and chronic dislocations. However, persistent acromioclavicular joint pain and poor long-term outcomes have limited its use. Distal clavicle resections have been proposed in symptomatic acromioclavicular joints resulting from previous dislocations. However, excessive resections may result in additional acromioclavicular instability. Unfortunately, patients' outcomes have been generally poor with increased horizontal and vertical instability. The conservative treatment of high-grade dislocations, stage 4, 5, and 6, with involvement of coracoclavicular ligaments or the trapezius fascia often yields unsatisfactory outcomes, 20 to 40%. For this reason, I strongly advise for surgery for stages 4, 5, and 6. Therefore, these injuries are treated surgically with the previously mentioned surgical options. Acute injuries may be stabilized with constructs such as hook plates or suture buttons. Both techniques reduce the joint and act as an internal brace while the ligaments are allowed to heal, especially in the acute cases, in an adequate position. Good outcomes have been reported with both hook plates and double suture buttons. Complications with these techniques include hardware migration, as I spoke about previously, loss of reduction, wound problems, osteolysis around the screw. It is important to act promptly in acute repairs to take full advantage of the biologic healing window. We like to do these acutely, quickly, when the healing process is still present. You have to insert loops. You can do a transfer of the coracoacromial ligament into the clavicle. All these are indicated. We don't like to use the tight figure-of-8 band with pins, because these migrate. We have removed pins from bad positions, and as a matter of fact, one patient lost his life due to migration of it. Even if you bend them, they can migrate. So you have to be very careful. The results and complications, some key principles must be taken into account to achieve good functional outcomes. Anatomic and accurate reduction of the joint is mandatory to prevent recurrent superior displacement and anterior posterior instability. Biological aspects enhance late stability. Therefore, direct repair in acute injuries and ligament reconstruction in chronic cases is highly recommended. Soft tissue repair or reconstruction must be initially protected with loops of synthetic materials, suture or tape or rigid implants. Repair of the deltoid and trapezial fascia must be formed in high-grade injuries. Distal clavicle resection may increase. Post-operative instability should be considered with caution. However, resection may be an option in chronic cases with radiographic or clinical evidence of acromial joint osteoarthritis. The complexity of the local anatomy and biomechanics makes the acromioclavicular joint susceptible to several complications. General complications include residual pain or instability, infection, and soft tissue ossification. Chronic pain after surgery may be a disabling condition. Possible causes of chronic pain include a horizontal instability, anterior and posterior, of the clavicle, subacromial disease, or neurologic injury. Loss of reduction has been reported in up to 28% of cases with poor clinical outcomes. Loss of reduction may be due to poor surgical technique or compliance with the post-operative protocol. This I have mentioned. If the arm is not protected in a sling or immobilizer for an appropriate period, the reconstructed joint is replaced or is placed under high static forces affecting the stability. Post-operative infection rate ranges from 0 to 9%. Corococlavicular, I have seen quite a number of corococlavicular ossification has also been reported with an incidence of 50 to 85%. Specific complications have variable rates according to the differential surgical techniques. Goring et al. Reported an early post-operative complication rate of 43% with a tension band circlage, 58% with a hook plate, 17% with PDS cord. At 35 months, the residual stability rate was 32% with a tension band, 50% with a plate fixation, and 24% with PDS cord treatment. Complications after distal fracture resection included excessive resection, as I have repeatedly mentioned, with violation of the ligamentous structure. Residual instability or insufficient resection when less than 5 millimeters. It has to be 5 millimeters. Otherwise, they can have persistent pain. Failure of fixation devices leads to loss of reduction and possible hardware migration. Osteolysis around screws. I have seen it a lot around Bosworth screws. Why? Because the surgeon failed to widen the area of the proximal screw. Why? Because you know that there is a certain amount of rotation, motion in all directions. This would produce erosion and osteolysis. And this weakens the bone, and they can have fractures. In a series by Fossa et al., osteolysis was 20% at 1 year and 65% at 4 years. Arthroscopic techniques in the treatment of acromioclavicular joint dislocations have been popularized for their advantages over open approaches, such as reduced soft tissue dissection, decreased skin and wound complication rates, and easier rehabilitation and earlier return to work or sport. However, the drawbacks to arthroscopic technique include it's a higher cost, no doubt, longer operation times, more difficult visualization of the anatomic landmarks. Poor visualization may have a dramatic impact on tunnel positioning when you're passing these loops through the tunnels. If they are improperly put, then you will have problems. This can lead to also loss of reduction, osteolysis, and fractures and hardware migration. So in conclusion, acromioclavicular joint injuries are common in current practice. They often result from direct trauma, disruption of the acromioclavicular ligaments leads to anterior to posterior instability, while failure of the coracoclavicular ligament results in superior instability. I have mentioned this so many times, and I hope that you'll not forget this. Recognizing concomitant injuries is helpful in decreasing complications and poor outcomes. The bilateral Zanca view is essential for the diagnosing and staging of the acromioclavicular joint injuries by allowing for more accurate comparison of the coracoclavicular distance. Appropriate treatment depends on the severity of the clavicle displacement. A conservative approach is indicated in the less severe forms, as I've repeatedly shown, while surgery for types 4, 5, and 6. The treatment type of 3 injuries is debated. Don't forget this. The surgical approach is generally indicated in young and high-demand patients. Surgeons should be aware of the complications. Poor outcomes can be minimized by meticulous exposure, closure of the deltotrapezial fascia, reaming 5 millimeters or less for clavicle tunnels, spacing the lateral tunnel 20 millimeters from the AC joint, tapping tunnels, avoiding a distal clavicle excision, protecting the repair for 6 weeks in a brace. Good patient outcomes following an AC joint injury can be achieved when these clinical principles are followed. So enough for shoulder. Are there any questions before we go into the ankle and foot? Khalid, is there any questions? Saleh, are there any questions?
دكتور جون
Hey,
كيفك؟
عظيم.
الشباب إذا في حد عنده سؤال بورد يا شباب ممكن تعملوا رايز هاند اللي عاوز يسأل. فاهمين كل شيء؟
فاهمين كل شيء. إن شاء الله بالفحص بيفهموا كل شيء. شو رأيك؟
إن شاء الله. إن
Yeah,
شاء
no,
الله.
we'll go into the ankle and foot because we still have a lot to give. وهيدول بدي أعطيكم إياهم لأن بدي نخلص الماتيريال قبل الفحص الجاي تبع البورد. راح يكون عندكم a full review of the topics. مشان هيك اللي مرت الجاي شايفكم 50 different problems in orthopedics. هيدي مشان مرت الجاي and we will discuss and it's called questions and answers. Then 2 weeks after that, we will go back to the knee and below knee sport injuries. The foot and the ankle are the most commonly injured body parts in the athletics. And these injuries are often result in loss of playing time. They often result in loss of playing time. Many times following a rugby game, they come with multiple injuries around the foot and ankle. Basketball, volleyball, football. It is the money-making injury. A study of intercollegiate players in the National Football League scouting combined found that 72% had a history of foot or ankle injury, the most common of which were lateral ankle sprains in 40%, syndesmosis sprain in 17%, metatarsophalangeal joint injuries 13%, fibula fractures 9%. Such findings have led to increased interest in the diagnosis, treatment, and rehabilitation of these injuries. Acute traumatic and chronic overuse athletic injuries can often be treated non-surgically, though many of these disorders are often challenging for both the athlete and the physician. It is imperative for the physician to quickly recognize a pathology or circumstance that requests or requires surgical interventions. Let's go into the ankle injuries. The incidence of ankle sprains in the United States was reported to be 2.15 per 1,000 person years. Almost half of all the sprains occurred during the athletic activity. Basketball, 41.1%. Football, 9.3%. Soccer, 19%. These were responsible for the most ankle sprains. All these, basketball, football, and soccer. In a similar study, it was found that the sprain rate was 58.4 per 1,000 person years. 64.1% of sprains occurred during an athletic activity, most commonly men's rugby, women's cheerleading, men's and women's basketball, soccer, and lacrosse. So you can realize athletics from one side and ankle injury and even foot injury. All these go hand in hand.
دكتور جون.
ايه نعم.
دكتور جون.
ايه بدي شيل البوز.
الشاشة يعني متوقفة على السلايد واحد.
اوكي راح بعملها هلا اوضح او بدي ارجع فوت.
يمكن ترجع تفوت احسن لان هي متوقفه على سلايد واحد اللي هو الستدي اوف intercollegiated football players.
اوكي راح برجع شوف. See where am I up to which slide? 218. Okay, I'm going to close and then come in. هلا واضحة؟ خالد.
جون ها.
Okay.
أيوة.
Okay. In a similar study, ankle sprain I mentioned was 58.4 per 1,000 person years, and 64.1% of the sprains occurred during an athletic activity, most commonly men's rugby. We spoke about these, and lacrosse and basketball. All these are known to occur. Let's speak about lateral ankle sprains. They account for 35% of sprains. Syndesmosis sprains, 10%. Medial sprains account for 5%. If you look at ankle stability, it depends about the extrinsic elements, يعني ligaments and tendons, and the intrinsic elements such as the geometry of the articular surface. مين ما سألكم بالفحص on what does ankle stability depend on? Don't forget to mention that there are two types of importance. One, extrinsic elements, which are the ligaments and tendons, and the intrinsic elements, which depends on the shape of the joint, the geometry of the joint articular surface. The contribution of each element varies with the load level, the direction in which the forces is applied, and the integrity of the ligaments. In general, the ankle is the most stable in dorsiflexion. Why is it most stable? Because the ligaments are tight as you dorsiflex. When you plantarflex, they become loose, okay? And when low and is least stable in plantarflexion when unloaded. في شيء عم بيجي بضربي هون، انا كثير مضايق. When the ankle is loaded, articular geometry provides 100% of translational stability and 60% of rotational stability. The unloaded ankle, however, relies on ligaments. Why? Why does an unloaded ankle, which occurs in plantarflexion, lead to instability? The reason is a gap becomes much, and it depends totally on the ligaments, and it is not helped by the articular geometry. Okay, when the ankle is loaded, articular geometry provides 100% of translational stability and 60% of rotational stability. The unloaded ankle, however, relies totally on the ligaments. Between 70 and 80% of anterior stability is provided by the lateral ligaments. 50 to 80% of posterior stability is provided by the deltoid ligaments. 50 to 80% of rotational stability is provided by the lateral and deltoid ligaments. Lateral ankle injuries. First of all, let us look at the anatomy. You know that the ligament which is most injured is the anterolateral ligament, which is pointed out in this slide in the horizontal direction, which is injured in plantarflexion and inversion. The second ligament to be injured is the calcaneofibular ligament, which is between the fibula and calcaneus. and it is injured most in dorsiflexion and inversion. The posterior talofibular ligament is the largest ligament. I repeat, it is the largest ligament and is rarely injured. Ankle sprains are very common twisting injuries to the ankle that are the most common reason for missed athletic participation. Treatment usually includes a brief period of immobilization followed by early functional physical therapy. Rarely, operative management is indicated in the setting of syndesmosis injury with tibiofibular diastasis or chronic ankle instability with recurrent sprains. The diagnosis can be made clinically with swelling and ecchymosis of the ankle and pain with range of motion. Radiographs are only indicated when clinical examination meets the criteria. We call them the Ottawa ankle rules. This shows you a typical sprain of the ankle. On examination and putting the ankle in plantar flexion and varus, the patient will complain of pain. The lateral ligamentous complex of the ankle joint includes the anterior talofibular ligament, the calcaneofibular ligament, the posterior talofibular ligament. They are most commonly involved in low ankle sprains, and the mechanism is plantar flexion and inversion. This is the anterior talofibular ligament. The mechanism is plantar flexion and inversion. Physical exam shows a drawer laxity in plantar flexion. What I mean by drawer laxity is by holding the tibia firm and pulling on the heel forward in plantar flexion, it will displace. And this occurs when you have a tear of the anterior talofibular ligament in plantar flexion and inversion. The calcaneofibular ligament is the second most common ligament injury in lateral ankle sprains. The mechanism is dorsiflexion and inversion. Physical exam shows a drawer laxity in dorsiflexion. If you recall, I mentioned for anterior talofibular ligament, the drawer laxity is in plantar flexion. The calcaneofibular ligament, the drawer laxity is in dorsiflexion of the ankle with anterior traction on the heel and stabilizing the leg or tibia. Subtalar instability can be difficult to differentiate from posterior ankle instability because the calcaneofibular ligament contributes to both. The posterior talofibular ligament is less commonly involved. Let me show you here. You have the calcaneofibular ligament, which is torn on dorsiflexion and varus. You have the anterior talofibula, which is in a horizontal position between the fibula and the talus, is injured on plantar flexion and inversion, and they have an anterior drawer time on plantar flexion with traction on the heel forward. The posterior talofibular ligament is rarely injured, but it is the larger of the three ligaments. Relatively recent anatomic research provided important information on the qualitative and quantitative characteristics of these ligaments. The anterior talofibula, the primary restraint to inversion and plantar flexion, has the least strength of the lateral ligaments. It is 138.9 Newton. It resists anterior translation and internal rotation of the talus in the mortise. This shows you the anterior talofibular ligament, which is horizontal. You have to see it. It is horizontal. Don't forget it. As it goes into plantar flexion, it becomes slightly vertical, and then on inversion, it becomes tight. The calcaneofibula extends from the fibula to the calcaneus. It has a small segment extending between the talus and the calcaneus, and this is trained in dorsiflexion and inversion. When the ankle is in neutral position or dorsiflexion, we mentioned that the calcaneofibular ligament is the ligament and primary restraint to inversion of the ankle. Its average strength is 345.7 newtons, while the calcaneofibular ligament spans the tibiotalar and subtalar joints. Thereby, it reaches subtalar inversion. These show you these various ligaments. I spoke to you about the posterior talofibula being the largest, and it's rarely injured. Radiographic parameters have been defined to quantitatively describe these anatomic origins and insertions of the lateral ankle ligaments. Injury to the lateral ankle ligaments typically occurs during plantar flexion and supination, which combine inversion and adduction. In this type of injury, the anterolateral joint capsule tears first, followed by the anterotalofibular ligament and calcaneofibular ligament as the force of the injury progresses laterally. The anterior talofibular ligament is injured in 33% of ankle sprains, and the calcaneofibular ligament is injured in around 40%. A grade 1 lateral ankle injury involves stretching of the anterior talofibular ligament with mild tenderness, no evidence of mechanical instability, and the ability to bear weight with minimal discomfort is present. A grade 2 injury is a complete tear of the anterior talofibular ligament, usually accompanied by a partial injury of the calcaneofibular ligament. A grade 3 injury. May I just 1 minute, because I want to answer this phone. Abdullah عم بعطي محاضرة في شي من اوكي اوكي امين عامر عم بعت المحاضره، بعت لك اياها اللينك. اوكي اوكي يلا باي. So a grade 2 injury is a complete tear of the anterior talofibular ligament, usually accompanied by a partial injury of the calcaneofibular ligament. A grade 3 injury is complete rupture of the anterior talofibular ligament and calcaneofibular ligament. Symptoms of severe tenderness and pain are common, and weight bearing is difficult. In an effort to reduce the incidence and severity of lateral ankle sprains, numerous studies of varying quality have focused on identifying the risk factors. A level 2 study identified age, sex, race, and athletic involvement as risk factors. The highest risk of sprains was during 10 to 14 years in females and 15 to 19 years in males. Boys and men age is from 50 to 24 years. They had a higher incidence than their female counterparts. Women's age had a higher incidence than men in that age range. Athletic involvement was responsible for 45 to 50% of ankle sprains. The same database showed a race-based disparity. The incidence was substantially higher among those identified as Black or white than among those identified as Hispanic. Several factors may be related to the race-based differences in injury rate, including obesity, exposure to high-risk athletic activity, connective tissue properties, and skeletal foot morphology, specifically as related to the cavovarus foot. Additional risk factors assumed to be important include strength, proprioception, range of motion, and balance. But there is a high quality evidence to support these assumptions. The best evidence supports the belief that an earlier ankle injury is a significant risk factor for a second ankle sprain. One leads to the other in the same or contralateral ankle. Extrinsic risk factors are specific spurts of participation. Yani, they are related, and the level of competitiveness, playing surface, and shoe wear. Yani, we have observed that sprains of the ankle are more common during playing for competition than during the practice. So according to level 2 evidence, sports injuries of the lateral ankle is most common during wall climbing, rock climbing, indoor volleyball, basketball, women's cheerleading, game competition places an athlete at greater risk for an ankle sprain than practice participation. Why? Because they're competing. They want to do better. They want to have, they're fighting more for ankle. Meta of acute lateral ankle sprains. Current opinion, practice, patterns, and research studies support functional, non-surgical management as the a severe grade 3 sprain. Surgery for a severe sprain leads to a slightly better functional outcome than non-surgical treatment. I repeat, surgery for a severe sprain leads to a slightly better functional outcome than non-surgical treatment. However, surgery is more costly. This is what the Americans say. They depend very much on the cost. And there is a higher complication rate than non-surgical treatment, with a slightly higher risk of osteoarthritic change on MRI. Functional non-surgical treatment leads to a higher incidence of re-injury. However, rates of return to pre-injury status are similar at the surgical or non-surgical treatment. Non-surgical treatment was unsuccessful in 10% of Japanese athletes, and athletes who underwent surgery had a more rapid return to athletic activity. Only level 5 evidence suggests that surgical treatment is preferable for professional or elite athletes. In patients who received non-surgical treatment for a severe sprain, the outcome was better after cast immobilization for 14 days, not more, than after the use of a rigid stirrup, brace, or walking boot. Other evidence-based treatment.
Sorry for interruption.
ايه
يعني نفس الشيء
كمان
وقفت على
نفس الشيء. ليه هيك عم بيقول؟ let's see.
نفس الشيء.
هلا ماشي. هلا
لا يعني يمكن تعيد تشغيلها مرة ثانية.
طيب لحم نشيل.
ايوه اوكي
اوقف. هلا باين.
هلا بينت. ايوه ان شاء الله
اوكي
تمشي. ايوه
ماشي. طيب. No scientific evidence supports the use of ultrasound, laser therapy, electrotherapy, manual mobilization, extracorporeal shock wave therapy, hyperbaric oxygenation, or platelet-rich plasma. I think these are all a waste of time and money. This is what is reported in the literature. Evidence exists to support bracing or taping during the post-injury period until the rehabilitation is complete. So I repeat this because I want to stress it. No scientific evidence supports the use of ultrasound, laser therapy, electrotherapy, manual mobilization, extracorporeal shockwave therapy, hyperbaric oxygenation, or platelet-rich plasma. I've realized that everybody is using platelet-rich plasma. There is no suggestion that it is better treatment than just immobilizing and put the patient on a rehabilitation program. Acute surgical repair or lateral ligament rupture of the ankle is not always controversial. The indications include an open injury, a large avulsion, or in other associated pathology, such as dislocated peroneal tendons. Of course, you need to operate them if they are dislocated. Osteochondral fractures, they should be looked after, or else the patient will end up with osteoarthritis, or bimalleolar fracture variant with a complete tear of the medial and lateral ligaments. Even in avulsion fracture of the distal fibula heals readily without late instability compared with a purely ligamentous injury. Some evidence supports surgical treatment of a severe lateral ankle sprain, particularly in an elite athlete or a patient who does hazardous work and cannot risk persistent instability or re-injury. Evidence from high-level randomized studies confirms that the use of lace-up ankle braces reduces the incidence but not the severity of acute ankle sprains in basketball and football players. Evidence also supports the value of neuromuscular education and balanced training in reducing the incidence of recurrent ankle sprains. Residual disability after ankle sprain is reported to be present in 32 to 76% of patients. The disability usually is in one form of residual swelling, pain, and/or instability. Elucidating the cause of disability can be a complex and challenging process requiring a history and physical examination as well as radiography, CT, MRI, or ankle arthroscopy. A disability resulting from instability must be identified as functional or mechanical. Functional instability has been defined as the occurrence of recurrent joint instability and the sensation of joint instability due to the contributions of any neuromuscular deficit. The primary cause is injury to the joint mechanoreceptors, afferent nerves, resulting in impaired balance, reduced joint position sense, slowed firing of the peroneal muscles in response to inversion stress, slowed nerve conduction velocity, impaired cutaneous sensation, strength deficit, and decreased ankle dorsiflexion. So these mechanoreceptors that I have just mentioned are very important if present, prevent or decrease the incidence of sprains. Functional instability typically improves in response on a well-designed rehabilitation program. Mechanical instability, however, is laxity of a joint due to structural damage to ligamentous structures which support the joint. Mechanical instability can lead to altered joint kinematics and arthritic changes, which often require surgical correction. So, what should we do about it if we have a mechanical instability and even a functional instability together? The standard treatment of chronic lateral ankle instability has been the gold modification of the Brostrom procedure, which is an anatomic reconstruction of the anterior talofibular ligament and calcaneofibular ligament that has had good long-term results. What is the goal? What is it? If the calcaneofibula, if it's cut away, you shorten it or repair it. This is a superior retinaculum. What we do, we bring it more, as is shown over here, and we join it to the ligamentous tissue around the fibula. So these, the calcaneofibula and the extensor retinaculum, is used in support of the absence or the cut anterior talofibular ligament. This procedure has limitations related to poor tissue quality and hyperflexibility, the stresses imposed by large or elite athletes, and aggressive early rehabilitation. Several modifications or recommendations should be considered when the Brostrom Gold procedure is used, such as the use of an augmentation method for reinforcement and protection, anatomic allografts, reconstruction if local tissue is inadequate, and immobilization for an adequate period of time before aggressive rehabilitation. So I'm telling you this. We know that the ligaments, the lateral ligaments, the far majority can, when they are injured acutely, can be treated conservatively. We mentioned also that in elite sports people, we can do surgery on them to get them back earlier in the treatment game. But on the whole, lateral ligaments are treated conservatively, unless you have a peroneal tendon dislocation or displacement that you have to repair, or any tendon or anything which is cut completely. The calcaneofibular ligament is injured, but it's less than the anterior talofibular ligament. Yani, I would say that even both are nearly equal, but in both, you can treat conservatively. The posterior talofibular ligament is the largest of the three ligaments, and it's rarely injured. The medial deltoid ligament, or the medial ligament, you know that the deltoid consists of 4 ligaments that prevent the ankle from going into varus. And the ligament consists of a maximum of 6 bands, of which only the tibio-navicular ligament, tibio-spring ligament, and deep posterior tibio-talar ligaments are constant. This is something you should know. And these, we rarely have to repair them unless there is fractures associated with it, etc. These show you the types of ligaments that we have. We have the tibiocalcaneal, the tibiospring ligament, tibionavicular ligament, and enough is mentioned about these ligaments. These are the primary medial stabilizers of the ankle, and the deep anterior tibiotalar ligament and deep posterior tibiotalar ligament are intra-articular, but they are extrasynovial. The deep posterior tibiotalar ligament is the largest and at the deltoid complex. I won't go further than this. These prohibit eversion and abduction of the foot. The deep deltoid, primarily the deep posterior tibiotalar ligament, also resists external rotation. You have to memorize these. Valgus tilting of the talus within the mortise requires complete rupture of both the superficial and deep deltoid. So you have to think of this. And it takes considerable energy and force to disrupt these. The deep deltoid ligament was found to have a greater load to failure, and it is 713.3 neutrons. So you have to pay attention to this. So this is all you have to know about the deltoid ligament. Rupture, let's see over here. We have something, because I want to go to other section. Rupture of the deltoid ligament is rare in the absence of lateral ligamentous or fibular injury. We mentioned this. And in all patients, the physical examination must exclude syndesmosis injuries, lateral ligamentous injuries, fibular fractures, including high fibular fracture, and proximal tibiofibular joint injuries. You have to fully evaluate the patient. The posterior tibial flexor digitorum longus and flexor hallucis longus tendons also must be evaluated. Any associated neurologic pathology, such as tibial or saphenous nerve injury, should be noted. So these are as far as the deltoid ligament, and I'll tell you something. Comparison with the normal contralateral extremity is the key to appreciating subtle differences. So this is very important. The criteria for the diagnosis of medial instability are medial joint pain in the ankle region, a subjective feeling of giving way, and a valgus or pronation deformity that is correctable with posterior tibial muscle activation. The diagnosis is reinforced by an examination indicating excessive motion in external rotation, eversion, valgus, and posterior translation. Radiographs may suggest deltoid ligament injury, especially if there is an associated syndesmosis injury or fibular fracture. The presence of small avulsion fragments at the tip of the medial malleolus may indicate an acute injury in association with the history and physical examination. In a complete deltoid ligament injury, a valgus AP stress radiograph shows a talar tilt. Most such injuries are incomplete, and standard radiographs appear normal. As a result, the traditional gold standard for evaluating medial ankle instability is stress radiography. A gravity stress radiograph may be useful in the office setting for detecting an acute injury. MRI increasingly is the imaging modality of choice for defining injury to the deltoid ligaments and associated structures. Most deltoid ligament injuries can be treated non-surgically. Treatment is dictated by the associated injuries. Usually there is no need to repair the injured deltoid ligament because stabilization of the concomitant injuries stabilizes the ankle and allows the deltoid ligament to heal. I've seen many surgeons having a fracture of the fibula, and they say that the patient has tenderness over the deltoid area, and they go in and they claim that they're repairing the deltoid ligament plus plating of the fibula. Well, actually, this is not really indicated. Plate your fibula, get a good reduction, and that is this allows the deltoid ligament to heal. Functional management of grade 1 and most grade 2 isolated deltoid sprains with a pneumatic brace, a walking boot, or really a walking cast is sufficient for adequate healing, although the delay before return to sport usually is greater than after a lateral ankle sprain. All grade 2 or 3 medial sprain does not require surgery. If an anatomical reduction can be maintained by immobilization in a cast or walking boot. After the repair of an associated injury, such as a fibular fracture or syndesmosis rupture, stress fluoroscopy occasionally reveals persistent medial instability. The primary repair of the deltoid ligament is warranted in this circumstance. The use of suture ankles or a sutured only construct often is sufficient to stabilize the medial side of the ankle. Now we come to the interesting part of foot. So, a resume, ankle injuries, the deltoid ligament, actually it has 6 parts, not 4 parts, as I mentioned. And there are 3 which are the most important. And usually, this injury is rare. It's often associated with fractures of the fibula with displacement. But on the whole, if you reduce the fibula or you reduce the fracture-associated injury, most of the deltoid ligaments heal while in a splint or in a cast. If you have a complete tear and the patient was treated conservatively and is unstable, then you are justified to use an anchor and repair this ligament. These ligaments are rarely injured. It is the ligament that prevents external rotation and valgus of the foot. So, as far as ligaments are concerned, the lateral ligaments are more important. The most common ligament to be injured is the anterior talofibular ligament. The calcaneofibula also is commonly injured, but least is the posterior talofibular ligament. You have to know that it is the larger of the 3 ligaments. Now we'll go into syndesmosis injuries. This is interesting. The ankle syndesmosis is continuous with the interosseous membrane proximally and is located at the level of the tibial plafond. In most patients, the ankle syndesmosis forms a synovium-lined joint space. Several recent studies clarified the important anatomic features of this region of the ankle and provided valuable information related to injury interpretation, method of treatment, and anatomic reconstruction. Although the distal fibula and tibia are congruent, most of the stability in the syndesmosis comes from its ligamentous support, which includes 3 well-defined ligaments: the antero-inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, and the interosseous tibiofibular ligament. This shows you the interosseous membrane. Then, as you reach the tibial plafond, you have these ligaments, which are the interosseous ligaments, the anterior talofibular ligament, and the posterior talofibular ligaments. This is it, showing it from the front. This is from behind. And here is the posterior talofibular ligament and the calcaneofibular, looking at it from behind. This is from the front. Look at the interosseous membrane and the anterior and posterior talofibular ligaments with the interosseous ligament between. And there is some synovial tissue in this region. The motion that occurs between the distal tibia and distal fibula is limited, but includes an increase in the intermalleolar distance of approximately 1.5 millimeters as the ankle moves from plantar flexion to dorsiflexion. Rotational movement in the horizontal plane of approximately 12 degrees to 17 degrees, and an average of 2.4 millimeters of distal migration of the fibula. 2.4 millimeters distal migration, 1.5 millimeters as the ankle moves from plantar flexion to dorsiflexion. You have to pay attention. This is the intramalleolar distance. One 1.5, the other one is 2.5. When a force overstresses these limits of motions, ligaments tears, and for the bone fractures. Several mechanisms can produce such an injury, the most common of which is an internal rotation of the leg and body on a foot that is firmly planted, causing an external rotatory force on the fibula. The whole body and the leg internally rotates while the foot is fixed. And this is an external rotation. And this gives you the fracture and the avulsion and the diastasis. The wide spectrum of injuries to the syndesmosis complex ranges from subtle sprain to complete diastasis and instability, local swelling and tenderness after the acute injury quickly give way to diffuse signs and symptoms that make the diagnosis less obvious. This is an AP view of the ankle, which shows a type 4 syndesmosis injury. The cotton, the proximal tibial fibula or squeeze, the external rotation stress, the hop test, بنط الواحد على إجره hop test, weighted rotation, and cross leg gravity stress, specifically are designed to detect syndesmosis injury and instability, but neither these tests nor standard imaging methodologies, plain and stress radiographs, CT ultrasound, and MRI are completely reliable. None of these tests are completely reliable. We speak about the cotton test during the procedure by using a hook spread, the proximal tibular and fibular squeeze test, external rotation stress, a hop test, jumping on it, weight bear, weighted rotation. All these, they are not reliable, even with the CT scans, MRIs, and radiographs. These are unreliable. This is the external rotation test that we use. Just tell us somewhat, is there something happening in the syndesmosis? This is the cotton test. This is the deltoid valgus stress test. You have to know the anterior talofibular and calcaneofibular ligament is tested by grabbing the calcaneus and performing inversion, either in plantar flexion or dorsiflexion. More than 6 millimeters of widening of the tibiofibular clear space on the anterior posterior radiograph indicates a syndesmosis injury, but significant injury can be present in the absence of this finding. MRI has become the preferred diagnostic study for a suspected syndesmosis injury in a professional or collegiate athlete in the United States. MRI is useful for, let's say, correlating physical examination findings with syndesmosis injury and predicting time missed from sports based on the severity of findings. Non-surgical treatment is preferred for a stable syndesmosis injury. Rest, immobilization, and non-steroidal anti-inflammatory drugs and ice are used. PRP was found to be a useful additional treatment for stable injuries. Syndesmosis injury requires almost twice as much time before return to play as a severe lateral ankle sprain. A systematic review of the literature was found that time lost from spurts after a from sports after a syndesmosis sprain ranged from 10 to 52 days. Residual symptoms are not uncommon. One study found good to excellent ankle function in 86% of patients at an average of 47 months follow-up, although 1/3 of the patients had mild stiffness and 1/4 had mild activity-related pain. Surgical treatment is indicated for patients who have obvious diastasis on plain or stress radiographs, or who have undergone unsuccessful rehabilitation. High-level athletes with subtle diastasis and or in MRI confirmed tear of the syndesmotic ligaments may benefit from surgical stabilization, although this treatment is controversial. You have to keep this in mind. Ankle arthroscopy usually is warranted to inspect the joint and evaluate it for cartilage lesions. After the joint is debrided, it is stabilized with a screw or a suture button construct. There is mounting evidence that suture button stabilization is more beneficial than screw fixation. This shows you a suture button, fibula. The advantage is it's not a rigid fixation. And let us look. At first, we used to put screws around 4 centimeters above the ankle joint, and this was somewhat a rigid fixation. Many times we reduce the fibula in slightly non-congruent reduction. This maintains it. Why do we say we like to remove a screw? We like to remove the screw for one major reason, or two majors. One, that it doesn't break, and two, which is more important, when you remove the screw, it will give us a better chance for a non-congruent reduction to become more or less congruent. Suture buttons are less rigid and they hold well the diastasis. A screw typically is removed 3 to 4 months after implantation, although the need for screw removal has been questioned by recent studies. Nevertheless, screw removal has been shown to improve a mild reduced syndesmosis and improve pain and function. Despite considerable research related to syndesmosis injury treatment, significant controversy remains, and there is a lack of high-level evidence on optimal methods for diagnosis and treatment. Now we come to another interesting topic, which is osteochondral lesions at the talus and distal tibia. An osteochondral lesion of the talus is a common injury that is challenging to treat because of the peer healing capability of articular cartilage and the difficulty of access to all areas of the ankle joint. This shows you an osteochondral lesion shown by an arthroscopic photograph, which shows this lesion of the lateral talar dome after shearing injury to the right ankle. Talar cartilage is thinner than articular cartilage in the hip and knee. It's 0.89 millimeters thick compared with 3.3, or 2.9 millimeters thick femur, the patella, and tibial plateau are thicker than that of the talar cartilage. Osteochondral fractures and chondral injuries are common after ankle sprains, particularly when the injury is caused by landing from a jump or by high-speed running. Inversion trauma causes the talus to tilt in the ankle mortise, inflicting a compression injury of the upper medial corner of the talus. This shows you the talus, the medial end of the tibia is impinging on the talus, the medial malleolus. And you can have either an osteochondral lesion of the talus or that of the distal end of the tibia. The cartilage or bone on the articular surface of the tibia and fibula may be injured. The injury may vary from minor compression of the bone to major, a separated piece of bone leading to a loose body in the ankle joint. Look at this photograph. This tells you everything you want to know. You have a varus injury. You can get an impaction at several regions. One in between the lateral dome of the talus and the fibula, or another between the medial end of the tibial plafond and the medial dome of the talus, and the third between the medial malleolus and lateral portion of the talus. You can have even a fragment of bone which detaches and behaves as a loose fragment and gives you locking and further damage of the articular cartilage of the ankle, which is thinner from that of the patella, the knee, and the hip. Generally, the injury is not recognized when the initial trauma occurs, but eventually the patient seeks medical assistance due to persisting or recurrent pain. In addition, there may be stiffness and or locking. The ankle is not always tender palpation, but with time it is a quiescent destroyer. This fragment of bone would erode the cartilage. The end result would be degenerative arthritis. The mechanical properties of talar articular cartilage make it more resistant to the effects of aging, including development of stiffness and osteoarthritis in comparison with hip or knee cartilage. The characteristic finding in an osteochondral injury is pain aggravated by weight-bearing exertion. A history of injury is common in the diagnosis of osteochondral lesions of the talus. It is important to define the osteochondral defect as the source of pain through a thorough history and physical examination, diagnostic imaging, and occasionally an anesthetic injection to the ankle joint. Locking and catching are symptoms of a displaced fragment. You have to keep that in mind. In most patients who have a non-displaced lesion after supination trauma in the acute phase, the symptoms cannot be distinguished from the soft tissue damage. Chronic lesions classically present as deep lateral or medial ankle pain associated with weight bearing. Reactive swelling and stiffness can be present, but absence of swelling, locking, or catching does not rule out an osteochondral defect. Recognizable pain on palpation is typically not present in these patients. Some patients have reduced range of motion. After careful history and taking and physical examination, the ankle routine radiographs of the ankle are taken consisting of weight-bearing, anterior, posterior, mortise, and lateral views of both ankles. The radiographs may show an area of detached bone surrounded by radiolucency. The damage may be too small to be visualized on routine radiograph. By repeating the imaging studies in a later stage, the abnormality sometimes becomes apparent. A heel rise view with the ankle in plantar flex position may reveal a posteromedial or posterolateral defect. Staging of the lesion is helpful in determining the treatment. That's very important. And the Berndt Hardy Loomer radiograph system is commonly used. Type 1 is subchondral compression. Type 2 is a partially detached injury. Type 3 is completely detached. And 4 is completely detached and displaced osteochondral fragment. And type 5 is a cystic lesion. So this is very important to follow. CT and MRI classification systems have been described. MRI is helpful in identifying additional pathology, but it tends to exaggerate the extent of the osteochondral lesion. CT does not define soft tissue pathology, but it provides an accurate picture of the structural character of the osteochondral lesion and any cystic dimensions. So CT tells us and gives us an accurate picture of the structure of the osteochondral lesion. And it tells us more about the cystic lesions. The arthroscopic classification of osteochondral lesions follows the system established by the International Cartilage Research Society. The combined use of radiographs, CT, and/or MRI and arthroscopy is essential for optimal treatment of these lesions. Articular cartilage injuries are common in both severe sprains, acute or chronic, and fractures of the ankle. The incidence of articular cartilage injuries ranges from 63 to 95% in studies of both acute and chronic lateral ankle sprains and was as high as 30% in unstable ankle injuries. Sorry. If you have an osteochondral lesion, and if it's left untreated, what happens? The risk of post-traumatic ankle osteoarthritis increases significantly, and approximately 50% of untreated osteochondritis lesions were found to have later degenerative changes within the ankle joint. So this is very important to know. Non-surgical treatment of osteochondral lesions is successful in fewer than 50% of patients. And this factor, as well as the risk significant long-term effects, requires an effective surgical treatment strategy. Arthroscopic drilling of curettage, bone marrow, stimulation using microfracture, mosaicplasty, osteochondral autograft or allograft transplantation, and autologous chondrocyte implantation have been used to treat osteochondral lesions. This is an arthroscopic photograph which shows microfracture treatment of an osteochondral lesion of the talar dome. A systematic review compared the outcomes of treatments of articular cartilage lesions of the talus, including non-surgical treatment, excision curettage, bone marrow stimulation, microfracture, autogenous bone graft, transmalleolar drilling, osteochondral autologous transplantation, autologous chondrocyte implantation, and retrograde drilling and fixation. The primary outcome measure was the American Orthopedic Foot and Ankle Society hindfoot score. Curettage had a 77% success rate, and drilling had an approximately 66% success rate of the treatment of osteochondral lesions of the talus. In addition, 13 studies reported that 35% of patients had an excellent outcome after bone marrow stimulation. Osteochondral autogenous autologous transplantation had a good to excellent outcome in approximately 76% of patients, and autologous chondrocyte implantation had a 66% success rate. Bone marrow stimulation was recommended as the first-line treatment because of its high success rate, low morbidity rate, and relatively low cost. Supplementation of the bone marrow stimulation with viscosupplementation of PRP, micronized cartilage allograft, or mesenchymal stem cell had better results than bone marrow stimulation alone. Several factors may have a role in the success of treatment for osteochondral lesions. The location of the lesion, as well as the patient age, the sex, the body mass, the index, history of trauma, and duration of symptoms also can affect the clinical outcome. But discrepancies in results have made it difficult to confirm other predictors of the success or failure of osteochondral lesion treatment of the talus. A large lesion, including a lesion with a large cystic area, typically requires complex treatment, such as autologous chondrocyte implantation with or without stimulation, with or without simultaneous bone graft, autologous osteochondral transplantation with single or multiple plugs. This I have used several times, the mosaic plasty, or fresh talar osteochondral allograft. I obtained the bone from the knee, the condyle, the cartilaginous portion, which is not in use. And we had fairly good results. The only bad results, or not successful results, was when the osteochondral lesion was at the extreme corner at the area of the angulation, where we could not adjust the mosaic autografts to the proper location. You can use also autologous chondrocyte implantation, where you take out the cartilage, you send it, you culture it, you get more cartilage, and then you put it back over the area and you create a membrane around it to hold it in place. This shows you the various lesions, which are quite large. Treating the osteochondral lesions في شيء مشكلة عندي أنا. The problem. Treating the osteochondral lesions after unsuccessful bone marrow stimulation can be challenging, but autologous chondrocyte implantation was reported to be successful in 23 of 29 patients at a mean 8.3-year follow-up, and osteochondral autologous transplantation was effective in 18 of 22 patients who had undergone earlier treatment of an osteochondral lesion of the talus. Double plug osteochondral autologous transplantation, mosaic plasty were found to be effective for large lesions. And trust me, I have done this several times, and it has been very effective in comparison with fresh talar osteochondral allografts, which often leads to osteolysis, subchondral cysts, and degenerative tumors. Tibial osteochondral lesions are much less common than talar lesions, and only one tibial lesion occurs for every 14 to 20 talar lesions. No single area of the plafond is a particularly common site for these lesions. The limited available reports suggested that techniques similar to those used for the talus are effective. Many patients in the study had a concomitant procedure, such as removal of soft tissue or osseous anterior impingement, without a substantial reported change and outcome. Ankle impingement syndromes, this is an important topic. We get to see many cases. Anterior body impingement. Anterior ankle impingement is a common source of pain in athletes and is related to osteophytes on the dorsal medial aspect of the talar neck and the anterolateral aspect of the distal tibia. Athletes often have a palpable spur of bone that is painful to palpation and interferes with performance, particularly during cutting, push-off, and maximum dorsiflexion, which can be critical in sports such as alpine skiing. It is believed that bony impingement in the anterior ankle is a consequence of athletic activity that consistently places the ankle in extreme positions over a long period of time. A laboratory study of 150 kicking actions by 15 elite football players found that maximal plantar flexion and stretching of the capsule occurred in only 39% of the kicks, but that direct trauma to the anteromedial tibia occurred in 76%. A cadaver study found that the anterior capsule attaches to the distal tibia on average 6 millimeters proximal to the anterior cartilage rim, rather than near the spurring at the distalmost tibia. Lateral radiographs of the ankle reveal osteophytes on the anterior tibia and talar neck, often described as kissing lesions, although CT studies found that these osteophytes usually do not contact one another during dorsiflexion. Let's go into it. You see that these are the osteophytes we're speaking about, one on the dorsal aspect of the neck of the talus and the anterior rim of the tibia. Likewise, you can have osteophytes posterior. These impinge. This gives you the anterior impingement syndrome. This shows it on a photograph or anything you want, where the impingement occurs. Oh, there's something going on. Chronic changes in the talar surface can cause osteophytes. The osteophytes will increase the anterior impingement and cause pain. In some cases, osteophyte formation can be seen anteriorly on the tibia, causing a depression. Okay, you have the osteophytes present on the anterior tibia, and as it impinges on the talar neck, it causes a defect, a depression, and this is called the divot sign on the talus instead of an osteophyte occurring. So you could have an osteophyte with an osteophyte, one on the talus, one on the tibia, and these impinge. Or you can have an osteophyte on the distal anterior rim of the tibia with the neck of the talus from impingement. And this is called the divot sign. This shows you, this is the divot sign. You have an osteophyte here, but it's impinging on the neck, the divot sign. Don't forget. The Scranton-McDermott classification of ankle bony impingement is based on the radiographic size and location of the spurs, and the Van Dijk classification is based on the extent of osteoarthritis. MRI can be used to define additional pathology, articular cartilage injury, intra-articular effusion, and bone contusion. This is the Van Dijk classification. A grade 0 is normal joint or subchondral sclerosis. Grade 1 is osteophytes without joint space narrow. Grade 2 is joint space narrowing with or without osteophytes. And grade 3 is a subtotal disappearance, deformation of the joint space. This is the classification of osteoarthritic changes of the ankle joint, secondary to all these osteophyte impingement syndromes and other conditions. The treatment includes rest, ice, range of motion exercises, and corticosteroid injections for Van Dijk grade 1 impingement, osteophytes without joint space narrowing. If non-surgical measurements are unsuccessful, arthroscopic debridement of the ankle is recommended. According to one study, 90% of patients without joint space narrowing, Van Dijk grade 1, 2, or 3, and 73% of patients with pain of less than 2 years duration improved significantly. These patients typically do not have osteoarthritic ankles and therefore have a good response to arthroscopic treatment with spur excision. However, the presence of other symptoms, such as those from an osteochondral lesion of the talus, can affect long-term outcome. The outcome most commonly is related to the age of the patient, the size of the osteophyte, the ankle morphology, or an associated condition such as a chondral lesion. Although osteophyte lesions commonly recur, the improvement in function remains. Now we come to the opposite. The opposite is the posterior bony impingement. And this occurs on plantar flexion. This occurs in football players also. When they plantar flex their legs, there is impingement of the posterior margin of the tibia on the posterior end of the talus. And as a result, you end up having this lesion. People who play ballet are playing it and in such a position that they have a forced plantar flexion, such as the point and demi-point positions in ballet. The posterior tubercle or an ostrigonum is impinged against the posterior aspect of the tibia, causing pain. Pain may also be caused by the formation of osteophytes, and these come to loose. They may be loose and cause loose fragments. Flexor hallucis longus irritation may occur from impingement. or low-lying muscle belly impinging in the tendon tunnel. So be careful about this. Posterior impingement is caused by impingement between the posterior part of the talus and the tibia. Look at this ballet standing position. They impinge. The condition is usually called the ballet angle because it is common among ballet dancers. Forced plantar flexion, demi-point and point positions causes pain. The condition is also common in gymnasts and salsa players after kicks with the ankle extended. In patients with these types of symptoms, osteophytes usually develop posteriorly on the talus, or a prominent posterior process is present. The bone may become detached, creating a loose body. In some cases, an os trigonum is present. All of these conditions may irritate the flexor hallucis longus tendon as part of the impingement process. In os trigonum, a bone that is not detached, not attached to the tibia. This is found normally in approximately 10% of the population. However, not all have symptoms. In sports in which forced plantar flexion is frequent, an os trigonum may cause the impingement. The primary symptom is pain from forced plantar flexion. So you have to pay attention to this. The patient usually experiences posterolateral tenderness in the area behind the peroneal tendons, palpation of the flexor hallucis tendon through a range of motion on the posteromedial side of the ankle is important. Inflammation of or around the flexor hallucis longus tendon may cause symptoms, and the condition may occur simultaneously. MRI may be useful to clearly diagnose these structures that are involved. The injection of a small amount of 0.5 to 1.0 millimeters of local anesthetic can help confirm the diagnosis. This should be done using fluoroscopy or ultrasound guidance. Crepitations and triggering of the flexor hallucis longus should also be borne in mind as the differential diagnosis. Posterior ankle impingement is caused by irritation of the posterior structures of the ankle, usually as a result of compression in maximum plantar flexion. The bony impingement may involve the posterior malleolus, the posterolateral talar process, trigonal or steatus process, and os trigonum, the posterior subtalar joint, or the posterior calcaneal tuberosity. So this is a diagram that shows you the os trigonum where it occurs. It shows you the flexor hallucis longus tendon, and this can rub on it and give us symptoms. So one should know the anatomy of the posterior aspect of the talus, tibia, and the rest of the tendons and its relationship to the area. The ostrigonum, which is united lateral tubercle of the posterior process of the talus, and the posterolateral tubercle are most commonly involved in the impingement syndrome. Posterior impingement is seen in athletes who extensively use extreme plantar flex position, as is common in dance, as well as kicking and jumping sports. The athlete reports a deep pain anterior to the Achilles tendon during specific activities, such as jumping, kicking, or a push-off maneuver. A traumatic incident can be an inciting event, as in fracture of the ostrigonum or posterior talar process, but usually the symptoms are caused by overuse. The initial diagnosis is based on the patient's history and physical examination. The standard workup includes radiographs, which may reveal the presence of an ostrigonum or posterior talar process. MRI can detect the soft tissue and the bony edema that commonly occurs with posterior ankle impingement. The treatment of posterior ankle impingement begins with rest, ice, non-steroidal anti-inflammatory drugs, and avoidance of extreme plantar flexion. Physical therapy can be useful, as can selected posterior injections to calm the local inflammation. Non-steroidal anti-inflammatory drugs may be indicated, and if this does not work, a corticosteroid injection may be indicated. And if this does not work, a corticosteroid injection may be attempted, preferably under fluoroscopy guidance. If neither therapy is effective, arthroscopic removal of the ostrigonum, loose body, or osteophytes should be considered. Non-surgical treatment was successful in 6 of 30 patients with posterior impingement symptoms, and 35% of patients who received an injection reported pain relief. Surgical treatment is indicated after 3 to 6 months of unsuccessful non-surgical treatment. The traditional procedure involves open excision of the trigonal process or ostrigonum through a posteromedial or posterolateral approach. Although open surgery has been successful, arthroscopic excision and decompression of the posterior ankle has become popular during the past decade and is as successful as open surgery. All 16 patients who underwent posterior ankle arthroscopy had good to excellent healthy related quality of life and functional outcome scores at a mean of 32 months follow-up, and 93% had returned to their pre-injury athletic level. High-level athletes had a significant decrease in visual analog pain scale scores with an average return to pre-injury level 46.9 days after arthroscopic decompression surgery. Soft tissue impingement of the ankle. Impingement refers to abnormal entrapment or contact of structures resulting from pain or restricted motion. Impingement syndromes are a commonly recognized source of musculoskeletal symptoms in many areas, notably subacromial impingement of the shoulder, femoroacetabular impingement in the hip. Impingement syndromes are an increasingly recognized source of pain and disability of the ankle. Impingement syndromes in the ankle include a broad spectrum of pathology with varying etiologies and anatomic features and presentation. Although no official classification exists, these syndromes are generally defined by the particular anatomic area involved, specific anterior, anterolateral, and anteromedial, posteromedial, and posterolateral and syndesmotic impingements have been described. These pathologies are generally grouped into anterior and posterior impingement syndromes for simplicity. Anterior ankle impingement syndrome results from compression of structures at the anterior margin of the tibio-talar joint during dorsiflexion. In 1949, McMurray described footballers' ankle, a commonly observed condition in professional soccer players, involving anterior osteophytes of the dorsal-talar neck and distal tibia. The term was later refined to impingement exostosis by O'Donoghue in 1957 to include other patient populations. The nut in cracker posterior impingement syndrome is characterized by compression in the anatomic region between the posterior tibia and the calcaneus during plantar flexion. The operative treatment of posterior impingement was not reported until 1982 when House described treating a posterior block of ankle joint in a population of elite dancers. The presentation was later termed Talar compression syndrome. So ankle impingement is an increasing recognized cause of symptoms in an athletic population as our understanding of the etiology, pathogenesis, and presentation continues to evolve. Recent advancements in diagnostic and treatment techniques aim to improve outcomes. So you have to realize that you have these impingements of soft tissue that can happen. And they can happen in any of, for instance, the basset ligament, a well-described accessory band of the AITFL, and the extensor tendons can be the source of soft tissue impingement in the anterior ankle. This is the basset ligament, okay? The antero-inferior tibiofibular ligament is the basset ligament, and this can be impinged between the both bones of the ankle. Posterior soft tissue impingement results from repeated plantar flexion and traps tissue between the calcaneus and tibia, stenosing tenosynovitis of the flexor hallucis, longus hypertrophy of the posterior capsule, and enlargement of the posterior intermalleolar ligament also are common causes of soft tissue impingement in the posterior ankle. Medial impingement is less common, but was found to affect athletes. The patient's history and physical examination play an important role in the diagnosis of soft tissue improvement. Patients report a history of chronic injury to the ankle or participation in sports that predisposes them to impingement, such as basketball, volleyball, or gymnastics. Typically, there is tenderness to palpation along the anterolateral gutter or inferior aspect of the anterior inferior fibular ligament. So you have to pay attention. You have to know these impingement syndrome. So this is it. Now, I'm going to speak very briefly about foot disorders, heel pain, plantar fasciitis. Plantar fasciitis is a painful heel condition. It's caused by inflammation of the plantar fascia, aponeurosis at its origin on the calcaneus. Diagnosis is made clinically with tenderness to palpation along the medial tuberosity of the calcaneus that worsens with dorsiflexion of the toes and foot. Treatment is a prolonged course of pain control, Achilles plantar fascia stretching, and orthotics. Rarely surgical management is indicated in the cases of progressive symptoms that fail non-operative management. The common causes of plantar heel pain are plantar fasciitis, Baxter's nerve compression, fat pad atrophy, Achilles tendinitis, Haglund's deformity, stress fractures of the calcaneus, tarsal tunnel syndrome, and lumbospine radiculopathy. The plantar fascia is dense connective tissue that supports the arch of the foot, the medial and lateral bands. The two main bands of the plantar fascia run from the calcaneal tuberosity and insert on the plantar plates of the metatarsophalangeal joints and the base of the proximal phalanges. This shows you heel pain is an extremely common complaint with several common causes, and it is important to make a corrective diagnosis of the cause of the symptom so that appropriate treatment can be given. This strong band of tissue provides stabilization for the plantar arch of the foot as well as the first metatarsophalangeal joint through the windlass mechanism. Remember the windlass mechanism. The aponeurosis functions from heel strike to toe in the normal gait cycle to achieve hind foot inversion, tibial excursion, rotation, and transverse tarsal stabilization. So this is the windlass triangle, which is from the calcaneum, the tubercle, to the plates on the metatarsophalangeal joints, and this is rather or less elastic. The triangle shows the plantar fascia is susceptible to injury primarily through overuse. Long distance running and prolonged training regimens can lead to repetitive chronic trauma that can damage the plantar fascia. Acute injury also is possible and results in partial or complete tear of the plantar fascia that can lead to chronic injury. Patients typically report morning activity-related pain specific in the plantar medial aspect of the heel at the origin of the medial band of the plantar fascia. Pain is aggravated by direct palpation or by initial weight bearing and stretching of the plantar arch. Cavo-varus foot deformity and Achilles contracture are believed to have a role in the pathology of plantar fasciitis. These are the areas where you can have, first of all, a tear along the medial aspect of the plantar fascia. It is a triangle, and this is between connections from the heel to the plantar fascia of the metatarsal phalangeal joints and proximal phalanges. And if it's torn, it's usually torn from the medial aspect, and they will end up having pain along the medial aspect on the plantar aspect of the foot. Obesity and work-related weight bearing were found to be independent variables contributing to plantar fasciitis in evaluating a patient with heel pain. It is important to keep in mind the numerous conditions that must be considered in the differential diagnosis. This is the differential diagnosis. You can have any one of these calcaneus stress fractures, infections, subtalar osteoarthritis, systemic arthritis, neurologic disorders, fat pad atrophy, flexor hallucis brevis tears, heel pad atrophy, plantar fascia rupture, retrocalcaneal bursitis, gout, osteomalacia, Paget's disease, tumors, vascular disorders, all these. You have to learn a proper differential diagnosis. Calcaneus stress fracture and tarsal tunnel syndrome are the conditions most likely to mimic plantar fasciitis. A calcaneus stress fracture should be suspected with an acute exacerbation of heel pain or pain elicited compression of the heel. The diagnosis is confirmed by heel radiograph, in which the classic finding of stress fracture can be seen after several weeks. A bone scan or MRI often is indicated to rule out stress fracture and help determining the severity of the plantar fasciitis. Tarsal tunnel syndrome or nerve entrapment of the first branch of the lateral plantar nerve also should be ruled out. Patients with tarsal tunnel syndrome report radiating pain and paresthesia, and they often have positive Thinnell sign. So you have to pay attention to this. The most commonly involved nerve is the Baxter nerve, the first branch of the lateral plantar nerve, which is mixed motor and sensory nerve to the abductor, TGT, quinti, and the lateral border of the plantar surface of the foot. Most commonly, the nerve becomes entrapped between the deep fascia of the abductor hallucis and the quadratus plantae. The workup typically involves electromyographic or nerve conduction velocity studies to confirm the diagnosis. Non-surgical treatment is mainstay for almost all forms of heel pain. The treatment of plantar fasciitis focuses on non-steroidal anti-inflammatory drugs, activity modification, and dedicated stretching program of the plantar fascia and Achilles tendon complete. A custom-made off-the-shelf cushion in-shoe orthosis is used to control heel motion and prevent laying of the heel pad along with dorsiflexion night splint. So all these put together. More invasive treatments include iontophoresis, corticosteroids, PRP, or injection. High-quality studies have supported the use of non-steroidal anti-inflammatory drugs, fascia, and stretching without weight-bearing, calcaneal taping, and night splint. extracorporeal shock wave therapy, corticosteroid, all these have been used. Medial plantar fasciotomy typically is recommended after unsuccessful non-surgical treatment. The medial third of the plantar fascia is excised with maintenance of the lateral band to prevent collapse of the arch. The benefits of open and endoscopic release have been debated, but some surgeons prefer endoscopic surgery to decrease recovery time and lower associated morbidity. Recently, either surgeons have become proponents of gastrocnemius recession. Yes, I've done this many times in the treatment of chronic plantar fasciitis. You see it. If you examine these patients carefully who have plantar fasciitis, you see that they have a slight equinus tendency. And if you try to extend them into dorsiflexion, you see that they are really spastic. They prevent you from doing so. And it's due to shortening of the gastrocnemius. I usually do a gastrocnemius resection before doing a release, and I see how far this ankle goes up. If not enough, then I do my medial fasciotomy. I don't do a complete fasciotomy because if I do a complete, the whole longitudinal arch is damaged. Be careful about this. Okay, so you have to pay attention. Occasionally, you can have a rupture of the plantar fascia, and this is secondary from a sudden acceleration movement during an athletic activity. So don't forget this. And this injury typically is painful. Patients report a loud, painful popping sensation in the arch of the feet. Little evidence is available to guide the treatment, although the injury usually is managed non-surgically. 2 to 3 weeks of immobilization with a non-weight-bearing cast or boot with arch support allows the inflammation and pain to subside. Gradual weight bearing is initiated with a return to activity as pain and swelling allow. Now, this will be my last section, and I think it's the most interesting session. Lisfrank's injury. Tarsal fracture dislocations are more common than is reported in the literature. It is often missed and may be difficult to diagnose. Early diagnosis and treatment is the key to preventing long-term disability. They should not be considered as a sprain of the ankle or foot until proven otherwise. As many as 20 to 30% of these injuries are misdiagnosed or overlooked, especially in the polytrauma patient with other distracting injuries. Nowadays, it is seen more often in sports injuries. The 3 most common mechanisms responsible for injury are twisting of the forefoot, axial loading of the fixed foot, or crushing injuries. When missed or improperly treated, often results in planus or planovalgus and cavus deformities associated with forefoot abduction or adduction are seen. We had the occasion to review 19 patients. We had 15 males and 4 females. The ages ranged from 20 to 38 years. And the mechanism of injury was motor vehicle accidents, crush injuries, sport injuries, and one was secondary to diabetes. You know that in diabetes, they have softening of the ligaments, and it can lead to a Lisfrank's injury. All except one of the patients was seen for the first time in the emergency room, and one was a diabetic. All had considerable pain, swelling, and ecchymosis on the plantar aspect of the midfoot. 4 had considerable deformity as they had significant tarsal-metatarsal dislocation. 8 had their fracture associated with multiple injuries elsewhere. A Jones type of bandage support was applied as they were evaluated radiographically. Anterior, posterior, lateral, and oblique views of the foot and ankle were done on all. X-rays of the opposite foot was taken only when the fracture was not clear or the fracture was too comminuted for surgical management. CT scans were requested in comminuted fractures in defining and reconstructing the fracture. Accordingly, the classification is classified when you have a homolateral dislocation, a isolated dislocation of the tarsal-metatarsal joint, or a divergent injury. And this classification was modified and added to later on. An AP projection should reveal no step-off between the base of M1 and M2 in line, respectively, with the medial and intermediate cuneiforms. An oblique view should be taken, and it should reveal no step-off between M3 and the lateral cuneiform. M4 should be in line with the medial end of the cuboid. So these are landmarks that are very important and will tell you at least dislocation or not. There were 8 homolateral, 7 isolated, divergent, 3 cases. All were treated within the first 12 hours. 8 were reduced closed, and closed pinning was used across the joints to maintain the reduction. 10 were treated open, using 2 incisions, one dorsally over the second metatarsal and the other dorsally over the base of the fourth metatarsal. 3.5 screws and spanning plates were used to transfix the medial 3 tarsal-metatarsal fractures and dislocations, and pins were only used in tarsal-metatarsal 4 and 5. Non-weight-bearing cast was applied for 2 months, followed by weight-bearing in a cast for an additional month. The pins and the screws were removed after 3 to 6 months, respectively. In cases of pure dislocation, the fixation was kept for an additional 2 months. And we had type A injuries treated with open reduction, pin and screw fixation. Type B injury with dorsomedial displacement, you can see it by the lines drawn, was treated with closed reduction and pin fixation. Type C was treated with pins, screws, and spanning plates through the dorsal approaches. None of the patients had a compartmental syndrome in spite of the comminution of the fracture. This could be explained due to the early open reduction and release of the tension within the compartment. 8 patients complained of occasional pain 9 months along the longitudinal arch in the region of the medial cuneiform metatarsal joint or walking long distances. 6 have mild pain and in work in construction. 1 patient, a female, complained of pain in the longitudinal arch, mainly on wearing high heels. None of the patients available follow-up required in arthrodesis. Intrinsic stability of the midfoot is provided primarily by the bony architecture. The recessed keystone, we call this the recessed keystone. The second metatarsal lies in between the medial cuneiform and the lateral cuneiform, and in line with the intermediate cuneiform. It is recessed between these bones, so it is protected. For this reason, injury to it has to be with an avulsion or whatever. Another point is that usually displacement occurs dorsally. Why? Because of the trapezoid shape of the base of the metatarsals, 2, 3, and 4. So this prevents them from displacing plantar wood. Another point is that the plantar ligaments are stronger plantar wood than dorsal wood. Therefore, displacement is usual dorsal lateral, dorsal medial, or both. Transverse intermetatarsal ligaments are present in the bases of 2 to 5 metatarsals, while between the first and second we have Lisfranc's ligament. The Lisfranc extends from the second metatarsal to the cuneiform. And if it's avulsed, there is a fragment of bone which is called the flexine. So you have to know these points. Lisfranc's ligament is especially large, strong, structural, extending between the medial cuneiform and the base of the second metatarsal, reinforcing the bony stability of the base of the M2 between the medial and lateral cuneiforms. Now, you have to realize that there are 3 columns in the foot. The first, the medial column, the first column, which is the first tarsometatarsal and navicular cuneiform joint, and this has limited mobility. The one which is stiff is the intermediate, and it's between second and third tarsometatarsal joints, the navicular cuneiform joint. And this is rigid. And the lateral column, the fourth and fifth tarsometatarsal joints, and is most mobile. And this we need to remain mobile as it acts as a shock absorber. The dorsal aspect of this articulation is not reinforced by structures of similar strength. We know that the dorsalis pedis artery crosses Lisfranc's joint and dives between them to form the plantar arch, arterial arch. But if this is injured by fragments, it will give you this hemorrhage that is present on the plantar aspect of the foot. And if you get an avulsion of Lisfranc's ligament and you have a flexine, this fragment can lie between the 2 joints. And this is one of the factors that pair with the reduction of this joint. You have to test. Whenever you're in the emergency, you should be able to test for a Lisfranc injury. You have to hold the second metatarsal. Obviously, you should look for hemorrhagic areas on the plant aspect of the foot. If it's not present and you want to test, you hold the second metatarsal at the head of the metatarsal and you try to rotate it gently. If the patient has pain, you should be very careful for this lesion. Another point, you can test each of the tarsal metatarsal joints separately by doing the same procedure on the metatarsal head. So you have to palpate each of the individual joints. You should observe for small ecchymosis, and you ask the patient to try and bear weight. He won't be able to bear weight in these cases. You have to ask for an AP 30-degree oblique view, which is for the metatarsal 3, 4, and 5. And an AP view, you ask for a lateral view to rule out dorsal displacement of the metatarsal base. In addition, comparison views are frequently helpful in both the diagnosis of dislocation and determination of adequacy of reduction. Weight-bearing views should be taken in suspicious cases. At present, routinely used is a CT scan, and often an MRI scan is useful for suspected lift strength sprains. If the patient cannot bear weight, a short leg cast should be applied for 2 weeks, and the röntgenograms repeated with weight bearing at that time, 2 weeks later. Evaluation should be directed to the radiologic landmarks. A lateral radiograph, one should realize that a metatarsal should never lie more dorsal than its respective tarsal bone. Any fracture of the base of the second metatarsal, and even a small avulsion fracture, a flex sign should arouse suspicion of a tarso-metatarsal injury. So reduction can be blocked by this fragment of bone. It can be blocked by the tibialis anterior tendon, which can slip in between the injury between the first and second tarsal-metatarsal joint and prevent reduction. Between the third and fourth metatarsals, the peroneus longus tendon can slip and prevent a reduction if you do have a dislocation at that level. Interposition of a fragment from the base of the second metatarsal that is attached to Lisfrank's ligament, which is the flex fragment, and prevents concentric reduction of the second metatarsal into the cuneiform mortise. You have to pay attention to this. So think of it. Between the second and the first and second, think of the tibialis anterior, one of the bands. It can dislocate and lie in between these two and prevent reduction. Between the third and fourth, the peroneus longus likewise will cause it. Or you can think of a fragment of bone. You have to know that the digital artery goes in between, and this can be injured, and this is what causes the ecchymosis. You see that in a number of cases, there is ecchymosis. So you have to pay attention. Fractures presenting with more than 2 millimeters of displacement and greater than 15 degrees of talometatarsal angulation require operative treatment. Pure dislocations without fracture may have a worse outcome despite open reduction and internal fixation. So in conclusion over here, this frank injury is rare. Beware when swelling involves the forefoot. A sprain is a last diagnosis. I tell the younger residents, beware of a Lisfrank's fracture, dislocation. Beware. Don't arrive at the conclusion that this patient has a sprain until proven otherwise. I tell you, any weight bearing And taking an X-ray while weight bearing will show you this location. Or I'll tell you, if you're not convinced, you put the patient in a below knee cast, send him home, non-weight bearing. Bring him back, take off the cast, ask him to stand on his foot and take your X-ray, and you will prove whether it exists or not. If you have a multi-comminuted injury of that portion, you don't have this problem. And to describe it further, you can ask for a CT scan or and an MRI. Early diagnosis and management is a must to have a good result. This is assisted by an adequate, detailed history of the mechanism of injury and a good radiologic evaluation. It is seen more often in sports injuries. Early anatomical reduction is associated with a good and long-term result. When it is mainly ligamentous, it should be fixed surgically and kept off weight bearing for longer periods than when associated with a fracture. Closed, non-displaced, less than 2 millimeter injuries can be treated with percutaneous spinning with a non-weight bearing cast for 6 weeks, followed by a weight bearing cast for an additional 4 to 6 weeks. All displaced fractures should be treated operatively. I just want to mention briefly, know about the turf toe. Turf toe is a hyperextension injury of the plantar plate and sesamoid complex of big toe metatarsophalangeal joint, and most commonly occurs in contact athletic sports. The diagnosis is made clinically with the inability to hyperextend the hallux metatarsophalangeal joint without significant pain and the inability to push off with the big toe. A vertical Lachman test will show greater laxity compared to the contralateral side. So you have the treatment is rest, non-steroidal medications, and taping, tip-sole shoe, or walking boot in the majority of cases. Surgical repair is indicated for patients with progressive and persistent symptoms who fail non-operative management. Turf toe originally was described as a hyperextension injury to the first metatarsophalangeal joint caused by wearing flexible shoes on hard articular surfaces. But the definition has evolved to encompass almost any injury to the first metatarsophalangeal joint caused by sports participation. So the primary injury involves the plantar plate or the capsuloligamentous complex or the first metatarsophalangeal joint, which typically is injured in skilled position football. Players will actually load their heels when the forefoot is fixed on the turf. That's a turf toe. Paravalgus forces also can contribute to a turf toe, further destabilizing the joint with less integrity of the collateral ligaments. So this is enough. MRI is reliable for assessing the extent of the soft tissue injury. You can have an avulsion fracture, sesamoid fracture, diastasis of the bipartite sesamoids. This is showing you a turf toe. So this is enough for turf toe. Look it up. And sesamoid disorders, you have to look them up. Actually, many can result from sesamoiditis, infections, fractures, and give you the, oh, this is fractures, tendinitis, ligamentous injuries. This is a sesamoid fracture. And then I would like to stress one more thing, stress fractures. You can have stress fractures of many sites. You can have of the distal tibia, of the medial malleolus, have of the metatarsal bone, and you can have of the calcaneus and the navicular. So pay attention to these and look them up. This would be a nice review. They are seen occasionally in the calcaneus, fibula, talus, sesamoids, and navicular. You have to look up these metatarsal bones. Second metatarsal, the second and third are the most common to occur in most of the army recruit as they are training. They get this quite often. So that's it. Let's see if there's anything more I would like to mention. Fifth metatarsal fracture, this is very important. We divide this into three locations. One, avulsion of the tubercle. Two, at the junction of the metaphysis and diaphysis. And the third, in the diaphysis. What you need to know is that there is a high incidence of non-union in these fractures, and many times you have to insert the screw. Many times you can get non-union in these fractures. So you have to keep this in mind, and they will require bone grafting at times. But you should put the screw and apply compression to the fracture site. So this is enough for this type. It shows you a screw being in. I want to mention it. Also, you have to see, we occasionally see navicular fractures, which occurs secondary to running, explosive running, as during the Olympics. This is a fracture, you should treat it acutely. Screw in it. So I'll tell you, this is a topic in itself. I took it so as to just discuss this during the sports injury. Here we are. What predisposes individuals to medial malleolar stress fracture? You have a narrow tibia, increased external hip rotation, forefoot varus, subtalar varus, limb length discrepancy, tibial varus, pes cavus, and remedial osteophytes. So I'll tell you, these, you have to look them up and study them. I'm mentioning this just to let you know. Next time, I will discuss Achilles tendon disorders because we have no time for it. Okay, just briefly, you have to know this is, it occurs suddenly over time as one is playing, a middle-aged individual playing tennis suddenly feels as if somebody hit him from behind. And it turns out that Achilles tendon ruptures at around 4 to 6 months from its insertion. And this can be very painful. And there are two methods. One, conservatively, recurrence is higher in the conservative method. And treatment is by suturing. You can do it percutaneously, but you have to pay attention for the steral nerve. And or you can do it open and do suturing. Chronic lesions can end up with a gap, and you might need to use the flexor hallucis longus as a graft, or any of the tendons available for grafting in these cases. Enough is enough. I think I bored you enough, because you have to know that you have the Thomas test. We like to ask this question. When you squeeze the calcaneus and the foot goes into plantar flexion in a normal individual. If it doesn't, then you have to say that the Achilles tendon is ruptured. Also, if you put the foot on his the patient on his tummy and put the foot over a pillow, you see that there is a gap in the tendon, which tells you it's torn. You can use ultrasound, can use MRI to tell you and confirm. Overuse injuries, you have to really know more. And this is from too much training. You have to realize this. And that's it. And I wanted to give you so much, but I'll be very honest. Injuries and disorders of the foot and ankle are common among athletes and active individuals, although both lateral and medial ankle sprains are most common. Other subtle injuries will often occur. These can be difficult to diagnose. Clinicians must be vigilant and perform a thorough history and physical examination because we don't want to miss anything. The use of advanced imaging is often helpful in the diagnosis when combined with a thorough clinical examination. Many of these conditions can be treated non-operatively, though surgical management is sometimes indicated. With the appropriate treatments outlined in this presentation, good outcomes can be achieved. So the take-home message: ankle sprains represent one of the most common athletic injuries. Good evidence from high-level studies is available to guide management and treatment decision-making. Osteochondral lesions of the ankle respond poorly to non-surgical management, and surgical treatment continues to evolve. The surgical options have different indications. The causes and locations of ankle impingement are numerous, and both open and arthroscopic procedures are used. Plantar fasciitis can be mimicked by calcaneal stress fractures or a tarsal tunnel syndrome. Anatomic reduction is the most important factor in achieving a good outcome after a Lisfranc injury. A high index of suspicion should be maintained to diagnose a high-risk stress fracture of the foot and ankle. A prolonged recovery and delayed union or non-union are common after these injuries. Thank you very much. And don't forget that in 2 weeks' time, we will have 50 questions and answers. Topics will be discussed. Maybe we might not finish. To give you an idea on how we examine in the board exam. I thank you for tolerating my lecture. Maybe it could have been a bit boring to some of you, but I tried to cover it up all in 4 hours' time. Thank you. Khalid, you have any comment?
دكتور جون ثانك يو فيري ماتش. بصراحه يعني غطيت مواضيع هامه للشباب. شكرا لك يا دكتور.
هلكت يا خالد.
تسلم ايدك ويسلم صوتك. والله بنت عم تعبك الله يحفظك.
تعبني. طيب خالد don't forget فهمت خالد؟
اوكي
ايه بقى كل شيء بقول لك.
ايوه
This is becoming very popular. فاتوا الجماعة الليبية بالبورد ريفيو على هالميتينج عم بيحضروا بس
على هالميتينج
كويس. اوكي هذا اصلا من الاردن عم بيفوت علي بس انا ما بقدر اقول لك العراقي
من مصر من الاردن من كل مكان
في عم بيجي ناس من
عادي. الكل مسموح لهم يفوتوا يعني
اذا بتلاحظ تخلق.
ايوه عادي يعني يفوتوا. اهلا وسهلا فيك
خالد. فيك تحكي على 4 ساعات انت؟
دكتور ايوه
فيك تحكي على 4 ساعات فرد صاحبي؟
والله اتعب يعني لكن اذا انا محزن تمام.
طيب
الله يعينك يا دكتور. امس كان معنا محاضرات على المسكولوسكيلتال ايميجنج جبناها ساعه وتعبنا. انت ما شاء الله يعني الله يعطيك العافيه.
tolerating me. بس
شكرا لك.
هلا انا بنسى كل
Thank you.
الريزيدنت، بنصح كل الريزيدنتس يمسكوا كتاب يراجعوا كل شيء شو حكينا، بهالطريقة بتفوت لراسه
ايه
discussion. يمكن في توبكس ما فسرت كفاية، بس إذا بدي أفسر كفاية بدي دل لبكرة على بكرة عم بحكي بقى. مشان هيك ليه التزمت أقصر شوي. أوكي.
والله هم
طيب.
عم يسمعوك يعني، وبارك الله فيك، انت بتجيب لهم لب المواضيع والباقي
نعم.
عليهم يعني بالفعل، لان باقي مواضيع كثير لازم تتغطى صراحه.
أوكي يلا thank you very much and goodbye.
Thank you. You have a nice day.